কি তোমার আমার ল্যাপটপে কম্পিউটারটা দিছো, ল্যাপটপে কম্পিউটারটা Okay, good morning. How is everyone doing? Uh, Welcome to the 21st lecture of Dr. Hyder Step 1. Can everyone hear my voice? Can everyone hear my voice? Okay, perfect. Okay, good. So, welcome everyone to the 21st lecture of Dr. Hyder Step 1. For this week of lectures, we will be targeting on finishing neurology from the first day 2020. And neurology is one of the most highest yield topics in neuroscience. Neurology is Okay, can you guys hear my voice? Okay, perfect. All right. Okay, our apologies for that short delay in beginning the lectures. Okay, so perfect. So once again, welcome to the 21st lecture of Dr. Hyder Step 1. We are going to target on finishing neurology for this lecture. And we apologize for the minor delays that we had for beginning today's lecture. It's just for the increased surge of applicants that we had to consider for this lectures, and sending out the Zoom links were a bit of an issue. And we realized that every Monday, what we will be doing is we will be sending out the lecture links half an hour prior to the beginning of the lecture, so that it gives us proper time to figure out who are interested and who are not. Okay. So once again, that being said, first of all, did everyone have a good weekend? Did everyone have a good weekend? Okay, perfect. All right, great. Okay. Okay, I know a lot of students got really worried and scared, thinking they might not have received the Zoom link. Okay, but it's nothing like that. Okay, we will always give out the Zoom links to everyone, whoever asks, regardless of finishing their transactions. Um, if only they can let us know that they need an extension for a day or two. Okay, because we know that how many obstacles a medical student faces, especially an international medical graduate. Okay, so please, there is nothing to be worried about in regarding your receiving of the Zoom links. Okay, so good. Okay, thank you for asking. My weekend was pretty good too. Okay, my father is doing well. Okay, thank you. All right. So the thing is, so what I wanted to talk about were the lecture plannings for this week. Okay, the lecture plannings for this week. Okay, so our goal is to finish neurology by this week. And if we have to finish neurology by this week, we have to target on finishing a minimum of 11 to 12 pages of first aid every day. Okay, because neurology has around 63 pages, and neurology is one of the most biggest chapter that you can finish for the purpose of your step one. And it's not only important to finish everything in neurology. Okay, it's not only important to finish everything in neurology, but you have to understand and master the important concepts. Okay, so it's important that you have to master and the important concepts, and the amount of questions that you will be receiving from neurology is immense amount of questions. So, what I would ask you guys to do is for this week, after we are done reading first aid, before going to bed, or if you guys get a free time, since we are only going to target 12 pages, okay, please try to read them every day so that you do not have to review the neurology section again and again, okay? And if you can master neurology, then your scores in step one will be exceptionally high, and we hope that every one of the students will be extremely confident in answering every question from neurology after we are done with our lecture. With that being said, can we do a quick revision and recapitulation of the previous lectures? We won't be asking a lot of questions today because we have a lot to finish. Okay. But before we start doing that, all I want to know is, are you guys doing the USMLE U World questions? Okay. Did you guys find questions in the U World that were common to our lectures? Okay, perfect. Okay, so what are the, can you guys give me some examples of the questions that you guys faced in neurology that were common to our lectures? Can anyone give me some examples they faced, some examples of questions which they faced in U World that were common to our lectures? Yes, dermatology or some of the previous questions. Okay, acne, that's good. Eczema, squamous cell carcinoma, psoriasis, okay, comedones, lichen planus, okay. And then what else? Psoriasis, okay. So my question is, did you guys answer all of these questions with confidence? Because these are some pretty high yield questions. And if you guys could answer them with confidence, then our goal for the lecture has been reached. Okay, that's perfect. Okay, great. Okay, so what we will be doing is today, before beginning the revision and recapitulation, what we will be doing is we will be straight away starting our lecture for neurology. Okay, and we would be keeping the revision and recapitulation for the previous lecture for the end of today's lecture. The reason being is because our primary goal, our task number one, is to finish the 12 pages of neurology every day. Okay, so that's our primary goal. So that's exactly what we are going to do. So with that being said, is that okay with everyone if we approach neurology in this manner? Okay, perfect. Because I don't want to wear you guys out. Okay, and that's that. Okay, with that being said, let's begin our lecture on neurology from first day 2020. Okay, and even before that, I show you guys some of the pages of neurology. What I will be doing is I will be talking about the lectures in a separate page. And then later afterwards, what we will be doing is we will be going back to the text to see if we have missed out on anything. Okay, to see if we have missed out on anything, and then we will be covering them step by step. Okay, so let me just share my screen really quick. And okay, let's go. All right. So the first topic of neurology is where we talk about the embryology section, and that's how it starts with. Okay, and whenever we talk about embryology, we like talking about embryology from the get-go, from the beginning, from the absolute beginning. Okay, so we all know that after the zygote is we all know that first of all, when an ovum is fertilized by a sperm, okay, there's a formation of a zygote, and we know that the zygote gets implanted. And after implantation, can anyone tell me really quick what happens in week two? What happens in the second week? What happens in the second week? Yes, what happens in the second week, please? Okay. So in the second week, we have what happens in the second week. This in the second week, we have a bilaminar disc formation. Okay, in the second week, we have a bilaminar disc consisting of an epiblast and a hypoblast. Okay, in the second week of gestation, we have the formation of a bilaminar disc, which is the epiblast and the hypoblast. And then this epiblast and hypoblast forms another transforms into this tri-layer. And what is this layer called? What is this week called? This whole process called? And this happens in the third week of gestation. What is this process called? That is correct. This process is known as gastrulation. Gastrulation. Okay, so the process of gastrulation is basically the bilaminar disc, which contains of epiblast and a hypoblast, is converted to a trilaminar disc. That is an ectoderm, mesoderm, and an endoderm. Okay, so that's what it is. Now, what happens is this ectoderm over here. Okay, so a small part of this ectoderm. Okay, small part of this ectoderm, this comes down and this starts forming a tube. Okay, so it folds down, starts forming a tube. And what happens over here is over here you have a structure known as the notochord. Okay, over here they start giving rise to a structure which is known as the notochord. Okay, now what happens is you have an ectoderm, mesoderm, endoderm, and then you have a notochord over here. So what happens is the notochord comes in contact with the overlying ectoderm. Okay, okay, this is really important. The The notochord, what it does is it comes in contact with the overlying ectoderm, and once it comes into contact with the overlying ectoderm, it differentiates the neuroectoderm. Okay, this differentiates the neuroectoderm to form the neural plate. So what happens is you have this formation of a neural tube. Okay, and then what happens is this neural tube. Okay, this folds. This keeps on folding step by step. Okay, this keeps on folding step by step, and then finally it closes. Okay, it finally closes, and there is formation of, okay, so it finally closes all the way like this. Okay, did everyone understand this very small basic concept? What's happening over here, step by step, all the way from the zygote to the neural plate formation? Did everyone understand? Can I get some answers, please? Everyone? Okay, good. So this is basically very easy. Once again, you have a bilaminar disc. So after zygote is formed, there's a bilaminar disc, epiblast and a hypoblast. This converts into trilaminar disc by the process of gastrulation. Then a structure known as a notochord is formed. It comes in contact with the overlying ectoderm, and it induces the formation and it induces the formation of the neural plate and the neural tube. And this is the neural tube, and the overlying part is the neural plate. Okay, so once that is done, okay, so once that is done, after the whole process is finished, okay, after the whole process is finished, you have you have the whole formation of the neural structures. Okay, you have basically the whole formation of the neural structures. After the neural structures are formed, it gets divided into two plates, basically two plates. One is an alar plate. Okay, alar. Another one is a basal plate. Okay, basal. And always remember that the alar plate is dorsal, and the basal plate is ventral. Okay, meaning that the like alar plate, which is the dorsal plate, this plate over here is the sensory plate. Okay, and the basal plate over here is the motor plate. Okay, so what's happening over here is after it gets divided into the two parts. Okay, so all the structures, let's say we have cranial nerves which are purely sensory. Then we have cranial nerves which are purely motor. Okay, so cranial nerves which are purely sensory will come out from the alar plate or from the basal plate. Can I get some fast answers? Alar plate. Okay, right. So, and the cranial nerves, which are motor, will come up from the basal plate because the basal plate is completely motor. Okay, so that's what it is. And what happens is there are some regulations over here. Okay, so the regulations are basically the growth and proliferation, the future growth and proliferation of the basal plate is induced by the sonic hedgehog pathway, and we will be talking about the sonic hedgehog pathway in the future lectures. Okay, but just for now, try to remember that sonic hedgehog pathway is an important pathway for the proper growth and development of all the neural structures and for the proper placement of all the structures in certain in their certain normal positions. And this one, the alar plate, this is regulated by transforming growth factors. Okay, so transforming growth factors. So these are basically why are they regulated by the transforming growth factors, and why are these regulated by the sonic hedgehog pathway? The why is not the main answer. I mean, the main concern. The main concern is you have to realize that they basically are. I mean, that the alar plate is regulated by TGF, and the basal plate is regulated by the sonic hedgehog pathway. And instead of focusing on why it's happening, we have to focus on the fact that it is actually happening by these factors, because the Y is a very big path. I mean, the Y is a very big answer, meaning that like if you ask me right now that Y is transforming growth factor involved for the development of allar plate, I would have to break down each and every step, and that is beyond the scope of step one. Okay, so unfortunately, we all we have to do is memorize or keep in mind that TGF is important for allar plate development, and the sonic hedgehog pathway is important for the basal plate development. Okay, that's what it is. Last one, last high yield information is the days. Okay, so the days are basically the growth of the neural plate starts from the day 18, meaning that um, close to around the third week, okay, because from the third week, the three layers have been formed and it ends at 21, exactly by the end of the third week. So it starts around the day 18 and it ends at day 21. So these are some of the high yield information that we have to understand before we move forward for the embryology. So once again, what I love absolutely about first aid is they try to focus on everything from the genesis, not the genetics. Genesis meaning that they focus on everything from the absolute beginning. Okay, so once again, from the absolute beginning, you have a zygote. Zygote forms the bilaminar discs. Then it forms a trilaminar disc. Trilaminar discs have a notochord, which induces the overlying ectoderm to induce the formation of the neural plate and the neural tube. Okay, and then after the whole neural structures are formed, it gets divided into big structures. Okay, I mean two big um, positions. One of them is the alar plate, which is the sensory plate. Another one is the basal plate, which is the motor plate. The alar plate is regulated by TGF, and the basal plate is regulated by the sonic hedgehog pathway. And the 18s are from day 18 to 21. Before we move forward, okay, I will give you guys exactly 1 minute to keep all of these in mind, because I do not want to move forward until and unless I have realized that each and every one of you have understood and kept in mind. I will ask one physician question, okay? And that's what it is, okay? So what I would do is give you guys exactly 1 minute, okay? I will give you guys exactly 1 minute, and then I will ask you the questions. Okay, go. If anyone is done, please feel free to let me know. Sonic hedgehog, okay? Sonic hedgehog pathway. Sonic hedgehog pathway. Okay, if anyone is done, please let me know. Okay, so instead of asking a particular student, let's all answer at the same time because we don't have a lot of time today. So first of all, what I want to know is what are the structures that the alar plate gives rise to? What are the structures that the alar plate gives rise to? That is correct. Sensory. What are the structures that the basal plate gives rise to? Motor. Okay, very good. And the alar plate are regulated by which signaling path? Okay, by transforming growth factor. And the basal plate are regulated by sonic hedgehog pathway. Okay, what induces the overlying ectoderm to form the neural plate and the neural tube? Notochord. That is correct. Okay, so that's what it is. And what are the days from which the neural structure starts beginning to differentiate to form the neural structures? Day 18, and it ends in day 21. Okay, that is correct. And always remember that the notochord, okay, the notochord that is over here, the adult remnant of the notochord is the intervertebral disc. Okay, the intervertebral disc. Okay, and in the intervertebral disc, we talked about the fact that the intervertebral disc has two structures. That is the annulus fibrosus, and another one is nucleus pulposus. okay, nucleus pulposus. And notochord is important for the development of the nucleus pulposus, meaning that the notochord is the nucleus pulposus is the adult remnant of the notochord, and this is extremely high yield for USMLE step 1, and they will ask you this question time and time again, that what is the adult remnant for the notochord. You got a question on it. Okay, so that's good. So now you know that we're not making the questions up by ourselves, so that's what it is. And so that's that. Okay, so that's good. So once again, the notochord is the adult remnant of the notochord is the nucleus pulposus. Okay, good. Next thing what we want to focus on. Okay, the next thing what we want to focus on are the regional development of the structures. Okay, so now what we have is now we have the neural tube. Okay, and now we have the neural tube, and from the neural tube. Okay, so what happens is from the neural tube, now we have the neural tube, which gives rise to all the structures of the central nervous systems, right? So in the central nervous systems, we have the brain, and then we have the spinal cord. Okay, and now what's happening is the tube is differentiating into different parts of the central nervous system. So first of all, let's focus on the brain section. Okay, the brain sections. Okay, so first of all, what's happening is you have the tube over here, and it's dividing into this popsicle-like structure. Okay, so this weird-looking popsicle. Okay, and what's happening is the first one. Okay, the first one is a pro. Okay, why is the first one a pro? Because the first structures are always the professional structures, meaning it's a mnemonic. Okay, it's just a mnemonic. So the first one is a pro. The second one always messes up. Okay, the second one is a mess. So if you have three brothers over here, okay, if you have three brothers, the first one is a professional. Okay, the second one always messes up, and the third one over here roams around. Okay, the third one, what he does is he keeps on roaming around. Okay, so it's just a mnemonic for you to properly remember that what are the different what are the different layers of, I mean, the different sections of the brain called. Okay, so once again, we have three brothers. The first one is a professional, very strict, disciplined. Second one is a mess up. Okay, always messes up. The third one keeps on roaming around here and there. So our first brother over here, he is prosencephalon. Our first brother is prosencephalon. Our second brother over here, who always messes up, he is mesencephalon. And our third brother over here, who keeps on roaming around, he is rhombencephalon. Are we clear? Did everyone understand? Prosencephalon, mesencephalon, and rhombencephalon. Okay, so once again, who is the first brother? What does the first brother do? Can we get some faster answer? Professional. The first brother is a professional. What is wrong with the second brother? He always messes up. Okay, what is wrong with the third brother? Roams around. Okay, the third brother always roams around. Okay, okay. So the name of the first brother is prosencephalon, mesencephalon, and the rhombencephalon. Okay, and now what's happening from the prosencephalon is from the prosencephalon you have the rise of Okay, one second. Let me just draw it out. This, excuse me, and this one. You have this one. Okay. Okay. So, okay. So the first brother, what he does is, he makes a telephone. Okay. He makes a telephone call. Okay, and then in the telephone call, he hears about some unfortunate bad news, and then he dies. Okay, so TD. So these mnemonics are extremely silly. You do not have to use them. Okay, you can make your own mnemonic, but for the purpose of properly remembering these things, because the reason why I'm focusing on these things is because you get direct questions from this. Okay, So what happens with the first brother? Once again, the first brother gets a very bad phone call, telephone, and then after he gets that phone call, he dies. Okay, so it's completely irrelevant, but just bear with me. Okay, next one. Next one is mesencephalon. Mesencephalon, and we know what's wrong with the second brother. He always messes up, so he keeps on messing up. Okay, so he always messes up, so he never changes. Okay, regardless of any phone call. Okay, and what happens with the third brother? The third brother, what he does is, okay, the third brother, what he does is when he keeps on roaming around, he meets someone. Okay, he meets someone, and after he mates. So after he mates. Okay, so what's happening over here is that the first brother who got a terrible phone call, terrible telephone call, and then he dies are your mnemonics for telencephalon and diencephalon. So telencephalon and diencephalon. Okay, and the second brother who keeps on messing up, he always messes up regardless of any situation. So he is still a mess. So mesencephalon is still mesencephalon. Rhombencephalon over here, the one brother who keeps on roaming around, he meets someone. This is metencephalon, and then he mates. So this last one is myelencephalon. Okay, so okay, now the thing is, okay, so is this mnemonic helpful? Because regardless of this mnemonic, okay, regardless of this mnemonic, what you have to do is you have to remember the names and the derivatives of all the layers of the brains. Okay, regardless of this, you can also use the one which first aid provides. Okay, first, I'm pretty sure first aid also provides a mnemonic, so you can also do that, but that has never worked for me. Okay, only my mnemonics work for myself, so you guys are at liberty to come up with your own mnemonics. So once again, the first part is known as prosencephalon. Then it gives rise to telencephalon and diencephalon. Second brother is a mess. Mesencephalon keeps on messing up, so still mesencephalon. Third brother keeps on roaming around. Okay, then he meets someone, so rhombencephalon, and then metencephalon, and then he mates, so it's myelencephalon. Okay, perfect. So once again, can I get some fast answers? Okay, what are the derivatives of prosencephalon? What are the derivatives of prosencephalon? What does the first brother do? Telephone and then die. Okay, what is the mnemonic for the second one? For the second brother, okay, he keeps on messing up, so he keeps on messing up. Okay, so it's mesencephalon. What is the problem with the third brother? He meets and then he mates. So it's metencephalon and myelencephalon. Metencephalon and myelencephalon. Okay. Okay. All right. Now, what we would do is we still, unfortunately, we still are not done. Okay. So the derivatives. So what we have to know is what's happening with the derivatives. So now we have this derivative. Okay. So now we have this derivative. Okay. Okay. Now, the first one is what we said before, that the first one is known as telencephalon. Okay, telencephalon, and always remember that from the neurological structures, you have two derivatives. You have two derivatives. One of them will be a wall. Okay, okay. One of them will be the wall. That is this wall covering all the way. Okay, and another one will be a cavity. Okay, so this cavity over here. So we have two structures that can derive from this. One will come from the wall, another one will come from the cavity. So what's happening from the telencephalon is from the telencephalon, from the wall, since this is the one, this is the one which is extremely high up, this is not very hard to understand that the telencephalon will give rise to the cerebral hemispheres, to the cerebral hemispheres. Along with that, the telencephalon will also give rise to the basal ganglia. Okay, does anyone know what is the function of the basal ganglia? What is the function of the basal ganglia? Yes. What is the function, please? So I know a lot of students get confused when or get extremely worried when they hear about basal ganglia. Okay. So basically, yes, that is correct. So movement. So basically, what basal ganglia is, if you have to put it in one sentence, that is the cerebral hemispheres before the proper impulses are provided to the muscles. The basal ganglia remotes tweaks it, increases or decreases that movement according to previous memories. Okay, according to previous memories. Okay, and we will solidify this information in the future, so do not worry. So once again, the telencephalon gives rise to the cerebral hemispheres and the basal ganglia. Okay, and what is the cavity responsible for? The cavity of the telencephalon. The cavity of the telencephalon is responsible for the development of the lateral ventricles. Okay, and what it is I'm not sure if you guys are well accustomed to the proper CSF drainage. Okay, so what we have over here is we have how many lateral ventricles do we have? Let's see if anyone knows how many lateral ventricles do we have. Two lateral ventricles. Okay, two lateral ventricles. Okay, so two lateral ventricles for two hemispheres. And then where does the movement of the CSF goes from the lateral ventricle? Lateral ventricle. Where does it go? Okay, good. So from the lateral ventricle, it goes to the third ventricle. From third ventricle, where does it go? Okay, CA. By CA, I'm pretty sure the Dr. Tying means it's cerebral aqueduct. Okay, it's to cerebral aqueduct. And through cerebral aqueduct, where does it go? Where does it go? Fourth. Okay, okay, fourth. And where does it go from the fourth? Does anyone know the name of the two foramens? Foramen of Luschka and Monroe or Magendie? Magendie. Okay, that is what I remember. I doubt if it was Monroe or not. Okay, it was not Monroe. It was Luschka and Magendie. And through from the fourth ventricle, what this does is this goes out to the foramen of Luschka and the Magendie, and then it gets absorbed. Okay, and then who absorbs the CSF? Who absorbs the CSF? Arachnoid granulations. Okay, and then from over there, it's absorbed by the arachnoid granulations, and then it goes out through the dural venous sinuses, and from the dural venous sinuses, it goes and circulates in the blood. Okay, and it goes to the the superior vena cava, and then to the heart. Okay, and that's that. Okay, so that is the whole process of the CSF circulation. We will be solidifying this information in the future just for the purpose of letting you guys know that the ventricles are there. So the lateral ventricles that we talked about, the lateral ventricles are coming from the telencephalon. Okay, so they're coming from the telencephalon. Okay, next one. Next one is the next one is okay. So we know that the telencephalon is giving rise to the lateral ventricles. The diencephalon, okay, the diencephalon, okay, the diencephalon gives rise to very important structures. These are the thalamus, hypothalamus, okay, and the retina. So thalamus, hypothalamus, and the retina. Okay, and the cavity that it gives rise to, the cavity that it gives rise to is the third ventricle. Okay, you will realize that the order of the ventricles are exactly what we talked about. Okay, so it's very easy to remember the names of the cavities. Just the names of the walls are a bit difficult. Okay, that's that. Next one. Next one is your second brother, obviously. Your mesencephalon, your mess up brother. Okay, the mesencephalon, what they would do is the mesencephalon keeps on messing up, so it's still mesencephalon, and then mesencephalon gives rise to midbrain. Mesencephalon gives rise to midbrain. Okay, and the cavity is responsible for giving rise to the cerebral aqueduct. The cavity is responsible for the giving rise to the cerebral aqueduct. Okay, then the next one is rhombencephalon, the brother who keeps on roaming around. Then he meets someone. Okay, and then he mates, right? So metencephalon and myelencephalon. And the menincephalon, what it does is the menincephalon is giving rise to the pons, and the menincephalon is giving rise to the cerebellum, okay? And the myelencephalon, what it does is the myelencephalon, this is the midbrain, and the myelencephalon gives rise to the medulla, okay? To the medulla. And from the mesencephalon, we have the upper portion of the fourth ventricle. And from the myelencephalon, we have the lower portion of the fourth ventricle. Okay, we have the lower portion of the fourth ventricle. So once again, the walls, okay, the walls are a bit important. So the walls are giving rise from the telencephalon, we have the cerebral hemispheres, the basal ganglia. From the diencephalon, we have thalamus, hypothalamus, and retina. From the mesencephalon, we have the midbrain. From the mesencephalon, we have pons and cerebellum. From the myelencephalon, we have the medulla. Okay, how will you receive questions about this in the U world? Okay, U world will have direct questions, absolutely direct questions, where they will tell you that you have a patient who comes with some sort of a neurological problem that is completely irrelevant to their question. And their question is basically they would want you to know, I mean, they would want to know whether you understand the derivatives of these neurological structures. So they will directly ask you that there is something wrong with the patient's, let's say, medulla. And then they will directly ask you, where is this coming from, or what is the embryological derivatives which gives rise to the medulla? And your answer should be Menincephalon. Okay, and in order for you to remember this, please do not forget the story of the three brothers. Okay, so once again, the story of the three brothers. The first brother was a professional. Once again, gets a telephone, dies. Second brother was a mess up, keeps on messing up. Third brother is this should be P. Third brother is he always roams around. Then he meets someone. Then he mates. Once you have these figured out, this whole thing, then you cannot mess up the walls, because the walls are also taking place in a direct order. Okay, so if you look at the structures of the brain, then you have the cerebral hemispheres at the top, then you have the basal ganglia, then you have thalamus, hypothalamus. Okay, then you have the midbrain. After that, you have the pons, and then you have the medulla, midbrain, pons, medulla oblongata. Okay, and even the cavities. Okay, the lateral ventricles come first, then you have the third, then the cerebral aqueduct, then the fourth ventricle gets divided into an upper portion and the lower portion. Okay, this is the easiest way you can remember, recall, review, and memorize all the informations about the structures really quick. Okay, so did everyone understand? Okay. Okay, so is this somewhat easy right now to review the whole information? Okay. Okay. Okay, good. So let me give you an important pointer. Okay, so you will come across a lot of texts in your medical career. Okay, if you cannot recall them, review them even after you have understood them. Okay, try to make a story about them. Okay, because our brain is structured to our brain is basically structured to recall and review informations when it is presented to us in a fun manner. Okay, so basically you can review, I mean, you can easily remember all the scenes of a movie, but you cannot remember the text from a book. That's because your brain has not registered that information in a proper way. Okay, so in order for you to register this information, what you have to do is you have to remember the story about the three brothers. Okay. Okay, next one. Okay, so you have the central nervous system and the peripheral nervous system origins. Okay, now what's happening is you have the mesoderm. Okay, and then after that you have okay. So you know what? Instead of writing this down, we're going to go back to our text and see what our text says and see if we have covered everything or not. Okay. Okay, so basically so let's start with our text today. Our text starts with neurology, embryology. Okay, and I'm pretty sure we have covered most of the high yields from this whole text over here. Okay, so first of all, what they are saying is they have said that the notochord induces the overlying ectoderm to differentiate into neuroectoderm and neuroplate. We covered this. that the two plates are regulated by two structures. I mean, by two signaling pathways, by transforming growth factor and the sonic hedgehog genes. We also covered that. We also covered the days. Then we also covered this whole diagram over there. Okay. Then the next thing which we have to focus is the central and the peripheral nervous system origins. Okay. And the peripheral nervous system origins are basically your neuroepithelia and the neural tube. So this is your neural tube over here. Okay, this is your neural tube over here, and you have this epithelial layer, which is known as the neuroepithelia. And this neuroepithelia, what this is doing is this is basically giving rise to the CNS neurons, ependymal cells, oligodendrocytes, and astrocytes. Okay, so CNS neurons, ependymal cells, oligodendrocytes, and astrocytes, and you do not have to recall and review this right away. What we will be doing is when we will study embryology from the reproductive section, okay, we have a proper breakdown of all the structures that are derived from there in a systemic manner. But just for right now, okay, just for right now, if you get any questions for if you get any questions in your U world when you solve the questions, just try to remember that the mesoderm, okay, the mesoderm, we have the ectoderm, endoderm, we have the ectoderm, mesoderm, and endoderm, okay. The mesoderm gives rise to the structure that is microglia. Microglia are basically the phagocytes of the central nervous system. Okay, that is what you have to recall and review. Okay, so is everyone clear from the first page? Do we have any questions? Do we have any questions from the first page? Okay, is everyone absolutely sure? Because I do not want to move on if anyone has any confusions. Okay, good. Okay, perfect. Okay, so from this, so let's start with the neural tube defects. The neural tube defects are a very high yield topic for the USMLE step one. Okay, the neural tube defects is what's happening over here is basically the neuropores. Okay, we have the neuropores. So we have the anterior neuropore and the posterior neuropore. Okay, so if the neuropores, they usually fuse at the fourth week. Okay, so if the neuropores they fail to fuse, okay, if they fail to fuse, what's happening over here is we have a persistent connection between the amniotic cavity and the spinal canal. So what's happening is this is the normal structure, okay, and these three are basically the high yield neural tube defects. So we have the spina bifida occulta, meningocele, and then we have the myelomeningocele. Before we read the text, let's address the diagram first. Okay, so what's happening over here is we have this first one over here, that is spina bifida occulta. So what's wrong with the spina bifida occulta is you have the spinal cord, and you also have the meninges of the spinal cord, which are intact. Okay, the only problem is there's an opening there's an opening behind the transverse processes. Okay, and this is a less commonly severe condition, and the spina bifida occulta is always presented by this tuft of hair. Okay, by this tuft of hair on the young patient's back. Okay, the second one is a meningocele, and what's happening with the meningocele is not only do we have a defect over here, what we also have is we have a herniation of the meningeal layer. So we also have a herniation of the meningeal layer, but the spinal cord keeps in place. The spinal cord stays in position, and this is a severe form of spina bifida occulta, and the most severe form is the myelomeningocele. And what's happening over here is not only do we have the meninges, we also have the spinal cord, which has herniated out. Okay, so we also have the spinal cord, which is herniated out, and these patients are are at extreme risk of morbidity and mortality. Okay, so first of all, what's happening is once again the neural tube, they take place because of failure of the neural pores to fuse. Okay, and the most important association is maternal diabetes and folate deficiency, and we know how important folate is during the development of during the normal development of the fetus, right? And what happens is during the early embryonic life, okay, if we do an amniocentesis, okay, if we study the amniotic fluid in the mother, if the mother's amniotic fluid is high in AFP, meaning alpha fetoprotein, okay, and increase acetylcholinesterase, so increase alpha fetoprotein and increase acetylcholinesterase, we can diagnose that this patient could have one of these conditions, that is spina bifida occulta, meningocele, or a myelomeningocele. Okay. So what is spina bifida occulta? Once again, the spina bifida occulta is the failure of the caudal neuropore to close. Okay, so we have the caudal neuropore, which is over here. They fail to close, and as a result, there stays an opening, but there's absolutely no herniation of the spina bifida occulta, meaning that the spinal cord and the meninges stay in place. The second one is your meningocele, in which the meninges will only herniate out through the bony defect. Okay, and the next one is a myelomeningocele, in which we talked about the fact that how the meninges and the how the meninges and the neural structure will also herniate out. Okay, the next one is known as myeloschisis. Okay, myeloschisis is exposed. Okay, so we have myelomeningocele. Unfortunately, they do not have a diagram for myeloschisis. So basically, myeloschisis is a more severe form of myelomeningocele in which they do not even have a skin covering. Okay, so there's no skin covering for myeloschisis. Okay, and that's that. And the last and high yield structure, the high yield condition for the neural tube defect is anencephaly. Anencephaly is basically what happens is we have two neuropores. One of them is the caudal neuropore, another them is the rostral neuropore. And for the rostral neuropore, what happens is if for some reason they do not fuse or close, what we have is we do not even have a forebrain. The patient, they do not even develop a forebrain, and the calvarium, it remains open. Okay, and what happens is the patient, they have polyhydroamnios. Okay, they have polyhydroamnios, and why does that happen? This happens because we know that the yeah, that the baby inside the mother. Okay, the baby is responsible for swallowing the amniotic fluid. Okay, and when the baby swallows the amniotic fluid, then the baby urinates that amniotic fluid out, and that helps to maintain a proper level of the amniotic fluid. So once the baby has absolutely no brain, okay, when the baby has no forebrain, the baby fails to develop a proper swallowing center. Okay, so the baby does not swallow the amniotic fluid, and when the baby does not swallow the amniotic fluid keeps on building up, and it results in excessive amniotic fluid, and that excessive amniotic fluid is known as polyhydramnios. Okay, so that's what it is. Did everyone understand the neural tube structures before I do that? I want to show you a diagram of anencephaly. Okay, so this is basically how a baby would look. Okay, so this condition is known as anencephaly, meaning that the rostral neuropore failed to fuse, and these babies have no forebrain. Okay, and they have an open skull, open calvarium. Okay, so this is known as anencephaly. And let's see a picture of myeloschisis. Okay, so this is basically a picture of myeloschisis or raceschisis, meaning that this shows that the spinal cord and the meninges have protruded out. Protruded out. Okay. Okay, so do we have any question? Okay. Another high yield information for the purpose of USMLE step one is for USMLE's for UWorld, they will ask you what is the basic cause of the neural tube defect. And the basic cause of the neural tube defect is basically the failure of the neuropores to close. That's one. And number two is there is also a failure of these bony structures. Okay, I'm not sure if you guys have received this question in UWorld or not, but another question is what is the basic problem with these neural tube defects? The basic problem with these tube defects are failure of fusion of the bony structures of the vertebra. Okay, and this is a very unusual answer that they expect in UWorld, but try to keep this in mind. They do not have this information in first aid. Okay, did any one of you guys read the question before? Did any one of you guys receive this question before? Which one? Which one? Which one did I give before? So basically, the question was that what is the primary problem with the development of the neural tube defect? The primary problem with the development of the neural tube defects are the failures of the neural pores to close. Okay, that's the primary answer. But some questions they also expect another answer, and that another answer is basically they want to know that if you understand that there is failure of fusion of the posterior portion of these vertebral bony structures. Okay, so please write them down in your book. And when you receive this question in UWorld, write it down in your book over here because you might also receive this question in your actual exam. Okay, okay. Next one. Next one is what we want to do is we want to address holoprosencephaly. Okay, so what is holoprosencephaly? Holoprosencephaly is basically the failure of the embryonic forebrain. And we know that the embryonic forebrain, which is the prosencephalon, prosencephalon, they differentiate into telencephalon and diencephalon. On how we remember this, we remember this by the way that our first brother was a professional who received a phone call and then he died, right? So if there is failure of that fusion, okay, if the prosencephalon it failed to fuse into it failed to separate into two cerebral hemispheres, the condition that takes place is known as holoprosencephaly. This is known as holoprosencephaly, and this usually takes place during the fifth to the sixth week. Okay, this usually takes place during the fifth and the sixth week. And what's happening over here is that over here we have a pathway that is the sonic hedgehog pathway. Okay, we have the sonic hedgehog pathway, and the sonic hedgehog pathway. What this does is the sonic hedgehog pathway is important for the proper development and for the proper positioning of the structures in the body, starting from the brain to even they're involved in the proper positioning of the arms. Okay, and we will be going and talking about the hedgehog pathway in the future. Okay, but for right now, this holoprosencephaly, the reason for this holoprosencephaly to occur is because there is an issue with the sonic hedgehog signaling pathway. Okay, so there is an issue with the sonic hedgehog signaling pathway. And what this happens is the easiest way that you can identify a patient with the holoprosencephaly is not only with sign symptoms of mental retardations, but there will also be midline defects. Okay, so what are the midline defects? The midline defects are basically cleft lip, cleft palate. And in the most severe form, the patients also have cyclopia. Cyclopia meaning the failure of separation of the ocular structures. Okay, and another one is what we can see is that this can also take place in uh, the syndrome known as Patau syndrome, which is a trisomy 13, okay, which is an extra chromosome on chromosome number 13. And this takes place also in Patau syndrome. Okay, so when you see this MRI, okay, of the brain, you see that there is a monoventricle. Okay, we have a monoventricle over here. And the star over here, I'm not sure if you guys can see this, but you can see this better in your own book. The star represents that there's a fusion of the basal ganglia. So we should have had the proper differentiations of the basal ganglia into two different structures, into two structures, but there is failure of fusion. Okay, I mean there is fusion, so I mean there's failure of separation. Okay, so once again there's a monoventricle. We talked about the fact how the ventricles are usually lateral and then third, but then over here you have one big ventricle and then you have one big basal ganglia and then you have one whole forebrain. Okay, and the way the patients usually look with a holoprosencephaly is somewhat like this. Okay, so this condition is known as holoprosencephaly, where you have, so if you see in this patient over here, in this patient, what you can see is this patient has a midline defect. Okay, so there is an absolute midline defect, meaning that all the problems that are happening are in the midline. As you can see that there is failure of separation of the ocular structures. Okay, this patient could also have a cleft palate. Okay, and and then also what's happening over here is that when you examine the baby, you will see that this baby has a monoventricle. Okay, meaning that they have exactly one ventricle and fusion of basal ganglia. So how can you identify a patient with holoprosencephaly? Once again, cyclopia, cleft palate, cleft lip. Okay, mental retardations. Okay, and the patients, when you do an MRI, you will see a monoventricle and fusion of basal ganglia. That's what it is. And And unfortunately, these babies have a very high mortality rate. Okay, so that's cyclopia. Cyclopia is failure of fusion, a failure of separation of the ocular structure. Okay, so this is cyclopia. Okay, like a cyclops. Okay, so that's what this is, cyclopia. Okay, so will you guys be confident enough to identify holoprosencephaly in the future when you receive a question of holoprosencephaly? Okay, so what are the signs that you would look out for if you have to diagnose a patient with holoprosencephaly? Can I get some fast answers? What's wrong with the eyes? What's wrong with the eyes? Cyclopia. Then, what is the problem? Midline defect. Okay. What is the problem with the cleft, with the lip and the palate? Cleft lip and cleft palate. What do you expect to see in these patients when you do an MRI? Monoventricle and fusion of the basal ganglia. That's correct. Okay, fusion of the basal ganglia. And what is the pathway that is causing this whole problem? Sonic hedgehog pathway. Okay, so sonic hedgehog pathway. Perfect. Okay, next one. Next one is known as lesencephaly. Lesencephaly. What is lesencephaly? Lesencephaly is basically how you have your brains over here. Okay, so we have okay, so 1 second. So we have the cerebral hemispheres, and we know that the cerebral hemispheres, they have a lot of gyri and sulci, right? So if this is your normal cerebral hemispheres, which with the gyri and the sulci, lesencephaly is that condition in which the patients do not have any gyri or sulci, and the patient's brain is smooth brain. Basically, the brain is absolutely smooth. Okay, so why is this happening? This is happening because there is failure of migration of the neuronal structure. So failure of neuronal migration, and this is associated with microcephaly, and ventriculomegaly. But if you ask us which is the highest yield is holoprosencephaly. Okay, you won't get a lot of questions from lesencephaly, maybe one. Okay, in which they would only ask whether you understand what lesencephaly means. Lesencephaly is basically a smooth brain. That's it, nothing else. You don't have to understand or remember anything else. But holoprosencephaly is high yield. Okay, so holoprosencephaly. Okay, so did everyone understand the second page? Do we have some question? Do we have any questions? Do we have any question from the second page? Okay. Okay, perfect. Okay. Next one. Next one is another embryological defect. Okay. This embryological defect. Okay. So once again, we are talking about some embryological pathologies already. Okay. We talked about holoprosencephaly, which is a pathology. We talked about neural tube defect, which is also an embryological pathology. And then we are going to talk about posterior fossa malformations. Okay. And this is a very high yield pathology for USMLE step one. That is KRE1, KRE2, and Dandy Walker malformation. So KRE1 malformation, KRE2 malformation, and Dandy Walker malformations. And these are extremely high yield. Okay. You have to identify and understand why these are happening. Okay. So first of all is KRE1 malformation. What is KRE1 malformation? KRE1 is basically you have the cerebellar tonsils. Okay. Let's okay. So over here, you can see is let me show you one thing really quick. Can you just give me 1 second? Okay, this is the image. Okay, so in the cerebellum, okay, this is okay. Let me show you. Okay, so over here in the cerebellum, you have this structure of the cerebellum, which is known as the cerebellar tonsil. Okay, this is the cerebellar tonsil. And this cerebellar tonsils, what this does is, what they do is they usually stay inside the closure of the calvarium. Okay, but if there is ectopia or there is misplacement of the cerebellar tonsils below the foramen magnum, okay, so you see this as a if you draw a whole diagram of the skull, you would see that the skull goes over here, and the tonsils, they should have been over here. Okay, so instead of staying over there, the tonsils, what they do is they herniate down. Okay, they herniate down, and this is a pathology. So this herniation of the cerebellar tonsils, which should have been over here to all the way over here, this is known as Chiari 1 malformation. This is known as Chiari 1 malformation. Okay, and this is usually asymptomatic in childhood, but if in adulthood, this can have some amount of cerebral symptoms. Okay, but what is the question that you will receive from Chiari 1 malformation? That is, what is Chiari 1 malformation? Chiari 1 malformation is basically your ectopia of the cerebellar tonsils below the foramen magnum. And what is the association? The association of the Chiari 1 malformation is syringomyelia. Okay, syringomyelia, and we will be talking about syringomyelia in the future. Okay, so syringomyelia is basically if you have this spinal cord over here, very roughly drawn, since syringomyelia, this is a pathological condition in which you have the development of this syrinx. Okay, so SYRI syrinx. So the syringeal structure which develops and it keeps on expanding, and this affects all the neurological structures which are going or passing through the spinal cord. And this association is highly important. So Chiari 1 malformation is associated with syringomyelia. So these are the two questions that you will receive from Chiari 1 malformation, nothing more. Okay, so do not get overwhelmed by these posterior fossa malformations. First of all, what is Chiari 1? Ectopia of the tonsils below the foramen magnum. What is the association? Syringomyelia. Done. Okay, next one. Chiari 2 malformation. Chiari 2 malformation is the herniation of the vermis and the tonsils. And realize how Chiari 1 is associated with an abnormality of one structure, and two is Chiari 2 malformation is associated with the abnormality of two structures. So what are the two structures? Those two structures are basically the vermis and the tonsils. Okay, so we have the cerebellar vermis. Let's see over here. Where is the vermis? Okay, there's tuber vermis. Okay, it's very unfortunate how we cannot find a proper picture for the cerebellum. Okay. Okay, so we will break down the cerebellum and the physiology, but just for now, just try to realize how the cerebellum has the cerebellar vermis and the cerebellar tonsils and the cerebellar hemispheres. Okay, and from the cerebellar the cerebellar vermis and the tonsils, they will herniate out to the foramen magnum. So instead of just the tonsils, now you have the vermis and the tonsils, which will herniate out through the foramen magnum with aqueductal stenosis, meaning that the cerebral aqueduct, which was involved for the drainage of the fluid from the lateral ventricles, I mean, from the third ventricle to the fourth ventricle, okay, that will be stenosed. And when you have stenosis of the cerebral aqueduct, the CSF will keep on building up, and this will give rise to hydrocephalus. This will give rise to hydrocephalus, okay? And what is the association? The association for Chiari 2 malformation is lumbosacral myelomeningocele. Lumbosacral myelomeningocele. So once again, Chiari 1 malformation, Chiari 2 malformation. What are the structures that are herniate out for Chiari 1? That's tonsil. Chiari 2 is vermis and tonsils. Next, in Chiari 2, we have another problem. What is another problem? There is aqueductal stenosis, okay, for which there is a hydrocephalus. What are the associations of Chiari 1 and Chiari 2? The associations of Chiari 1 is syringomyelia. The association of Chiari 2 is lumbosacral myelomeningocele. We talked about myelomeningocele a bit while back. If that myelomeningocele keeps, if that myelomeningocele occurs in the lumbosacral region, then that is known as lumbosacral myelomeningocele. Okay, and that's basically your Chiari 1 and Chiari 2 malformations. Okay, so do we have any confusions about Chiari 1 and Chiari 2 malformations? Anyone? Do we have any confusion about Chiari 1 and Chiari 2 malformations? What is the association of Chiari 1 malformation? What is the association of Chiari 1 malformation? Syringomyelia. Okay. What is the association of Chiari 2 malformation? lumbosacral myelomeningocele, lumbosacral myelomeningocele. Okay, so that's that. Okay. Okay, I was just checking the mail to see if any one of the students have missed out on the links or not. Okay, so my apologies. Okay, so next one is Dandy Walker malformation. Okay, so Dandy Walker malformation. So right now, with the problem with Dandy Walker malformation is Dandy Walker is the condition in which there is absence or agenesis of the cerebellar vermis. So the cerebral vermis has not even, I mean, it did not even form. Okay, so these are the issues with ectopia. Okay, and this is the issue with agenesis. Okay, and then Dandy Walker malformation is basically your agenesis or absence of the cerebellar vermis. Okay, so the cerebellar vermis is not present. As a result, what happens is that the cerebral vermis is not present. Always realize that when a neurological structure is not formed or not developed, that space is occupied by cystic fluid. Okay, so if you have absence of the cerebral vermis, that space is occupied by cystic fluid, and this gives rise to cystic enlargement of the fourth ventricle. Okay, this results in cystic enlargement of the fourth ventricle. So we have the we have the cyst over here. Okay, and what happens with this is this cyst, what this does is it fills up the entire posterior fossa. Okay, this fills up the entire posterior fossa, and this is also associated with hydrocephalus, and the hydrocephalus with which this is associated with is a non-communicating hydrocephalus. Okay, this is associated with a non-communicating hydrocephalus. Okay, so so what are the three conditions that we just talked about? The three conditions that we just talked about are number one, that is Curie 1 malformation, and then Curie 2 malformation. For Curie 1 malformation, we have ectopia of the cerebellar tonsils. For Curie 2, we have ectopia of the tonsils and the vermis. Okay, two questions. Next, what is the association? The association for Curie 1 is spina bifida occulta. The association for the Curie 2 is lumbosacral myelomeningocele. And in Curie 2, you also have aqueductal stenosis, for you get non-communicating hydrocephalus. Okay, done. Next one is Dandy Walker. What is the problem with Dandy Walker? Is there an absence or ectopia? There's an absence. Absence of which structure? Cerebral vermis. Okay, and we know that if there is an absence of a structure, this will be occupied by cyst. Okay, because none of the structures in the central nervous system will stay vacant. Okay, so when there is accumulation by cyst, this results in cystic enlargement of the fourth ventricle. Why is the fourth ventricle affected? Okay, the fourth ventricle is affected because the fourth ventricle stays in close proximity to the cerebellum. So if there is cystic enlargement of the vermis, okay, if there is agenesis of the vermis, this results in cystic enlargement of the fourth ventricle. Okay, so that's that. Okay, so did you guys understand these these three malformations? Okay. Okay, good, great. Okay, so that's what it is. Okay, next one. Next one is Syringomyelia. Next one is Syringomyelia. And we talked about this a bit while back, Syringomyelia, that what is the condition that's happening over here. So the main problem with Syringomyelia is basically, as I told you, that you have the spinal cord over here, right? And then you have this expanding syrinx. So there's tubular structure over here. Okay, this is formed, and what the problem is, not only is it there, not only is this structure there, this structure is also expanding over here. So this was the this was the initial this was the initial problem. So this structure over here, this same structure, this was the initial problem, and now this structure is expanding. Okay, and when it keeps on expanding, what it does is it affects all the nerve roots that are going through it. So there is a transection of the nerve roots, and the depending on the nerves that the syrinx affect, there is loss of action by those nerves. Okay, so let's solidify this information by this example over here. Okay, so we have the dorsal root ganglion over here. So we have the dorsal root ganglion. We know that the dorsal root ganglion, once it enters, it traverses in the mid of the spinal cord, and then it goes through this commissure over here. Okay, and then we have this one from one side, and this one is coming from another side, and there is a midline transection these um, of these neural structures, right? And now if we have this pharynx over here in the middle, okay, what this is doing is this is affecting the transection. And when you affect the transection of the dorsal root ganglion, we know that the nerves that are entering through the dorsal root ganglion, they're important for the pain and temperature sensations of the body. Okay, and if that's the case, then this is the lateral then this is the lateral tract. Okay, this is the lateral spinothalamic tract. Okay, so the lateral spinothalamic tract. So these are basically the two lateral spinothalamic tracts. So we have one coming from all the way to over here, then this is transecting, then this is going up, okay, through this commissure, and then we have another one which is coming through here, and then this transects and this goes up. So if you have the skewing once again over here, they will disrupt both of these nerves, and as a result what will happen is you have loss of temperature and the loss of the pain and temperature sensation at this affected dermatome. So everything below will be okay, okay, and everything above will be okay, but only the part that is affected by only the dermatomes that are affected by the Syringomyelia. Let's, for example, for this patient, we have the Syringomyelia which are affecting the C5 to T4. So the patient will have only loss of pain and temperature sensation at the C5 to T4. Okay. And also, if this keeps on expanding and this goes all the way to over here, okay, so not only will they affect the lateral spinothalamic tract, they will also affect the dorsal roots. Okay, and if they come all the way through over here, which can happen, okay, they will also affect the motor tract. So not only the patient will have loss of sensory, the patient will also get loss of motor functions. Okay, so once again, what is syringomyelia? Syringomyelia is the formation of a syrinx, and the syrinx usually forms around this structure. So there's loss of pain and temperature sensation is happening at first, and then depending on the expansion or and extension of the syrinx, the nerves will get affected. Okay, so let's read the text. So the text is basically saying that you have a syrinx within the central canal of the spinal cord. Okay, and what happens is you have the fibers which are crossing in that are typically damaged, and that we already talked about this. So these crossing fibers, which are the lateral spinothalamic tracts. Okay, so these fibers they are typically damaged, and what happens is when they are damaged, you have this loss of pain and temperature sensation. So if you look at this patient looks like he is wearing a cape. Okay, so this is known as a cape distribution. So this is known as a cape distribution. If no one knows what a cape is basically that extra layer of clothes which Superman wears. Okay, so cape. What is a cape? If any one of the patients, if any one of the students have a confusion, okay, what is a cape? So this is a cape. So you see this. So you see this patient over here. I mean, you see this child over here. You see the distribution of the cape. Okay, this distribution is exactly what they are talking about for this patient over here. So this is known as a cape-like distribution. Okay, why is there a cape-like distribution? Because there is bilateral loss of pain and temperature sensations due to the presence of the syrinx over here. Okay, and we already know that the syringomyelia is associated with KIRI1. We talked about this, that KIRI1 malformation is associated with syringomyelia, and KIRI2 is associated with lumbosacral myelomeniingocele. So if you have a patient with syringomyelia, also try to look for the fact, do an MRI of the brain to see if the patient also has an ectopy of the cerebellar tonsils or not. Okay, and that's that. Okay, next one. Next one is, what are the most common locations of the syringomyelia? The most common locations of the syringomyelia are the cervical, thoracic, and the lumbar. Why is the cervical portion the most common for syrinx to occur? Because always remember that the cervical portion has a bigger foramen. Okay, if you guys remember studying your cervical vertebrae in your anatomy, okay, then you have these big portions over here, these big portions of the cervical vertebrae through which the cord goes through. Okay, and this is highly high important for the development of the syrinx in the cervical portion. And then you also have the thoracic, then the lumbar, depending on the diameter of the neural structures over here. Okay, so are you guys clear about syringomyelia? Are you guys clear about syringomyelia? Do we have any confusions? Anyone? Does anyone have any question? Anyone? What questions do they ask? Okay. So what questions will you get from a patient about? So first of all, how do you understand that you are dealing with a patient with syringomyelia? Okay. So once again, they will ask you questions about syringomyelia. As they will tell you that you have a patient who has come to you with they will give you a lot of irrelevant informations in that question, and then what basically you have to figure out from that question is they will tell you that the patient's main problem is the patient cannot feel pain, or the patient cannot feel any temperature sensations in bilateral arm, forearm, and the upper part of the shoulder. So whenever they say something like that, you have to realize that they are talking about a cape-like presentation of the loss of pain and temperature sensation. And whenever they talk about a cape-like presentations, and if you have a patient who just has a bilateral loss of pain and temperature sensation, the first thing that should come to your mind is a syringomyelia, because the syringomyelia is extremely high yield for, is extremely important for the transaction of bilateral pain and temperature sensations, because they occur usually in this area, and this area is important for the transactions of these nerves. Okay, so they will have a direct question. Okay, okay, why are lower extremities not affected? Lower extremities are affected depending if the syrinx occur in the lower vertebral levels, but it's very uncommon. Okay, it's very uncommon for the syrinx to occur in the lower vertebral level, since they occur more in the upper vertebral levels, that is the cervical and the thoracic portion. That is why the okay, that is why the presentations occur at the upper levels. Okay, next question. It's first affect yes, it affects basically the lateral spinothalamic tract, the pain and temperature tracts. Okay, any more questions? Yes, what is your question, Dr. Noel? What is your question? Could you repeat the question, please? Yes, so your question in the USM is step one. Okay, so what is your question? Okay, so your question is basically, do they provide more clinical picture or MRI findings? They provide both. Okay, they provide both, but for neurology, they provide more clinical pictures. They provide more MRI findings, not the clinical pictures. Okay, and what we will be doing is after we are done with our first aid, we would be having an extra 1 hour to 1.5 hours of studying all the possible high yield MRI pictures of neurology. Okay, so you have absolutely nothing to be worried about. We will take care of everything. Okay, does anyone have any more question? Any more question? Okay. So, okay, good. So the thing is, would you guys be interested in taking a break right now or taking a break later? Okay. Okay, good. Okay. One second. Okay. So the next thing that we will be focusing on is the tongue. Okay. The next thing what we'll be focusing on is the tongue. Okay. So what's happening with the tongue is, okay. So what's happening with the tongue is before we go to this one. So first of all, we have the pharyngeal arches. Okay, I'm not sure if you guys know all the derivatives of all the pharyngeal arches, but we have the pharyngeal arches, which are the first, second, third, and fourth pharyngeal arch. Okay, so let's take another blank page over here. Okay, okay. So what's happening over here is you have the pharyngeal arches. Okay, and if we draw out a tongue all the way like this, okay, if we draw out a tongue all the way like this, okay, okay. So what's happening is the first and second pharyngeal arch. Okay, the first and the second pharyngeal arches. Are you guys? Do you guys know what the pharyngeal arches are? Do you guys know what are the pharyngeal arches? Okay, good. Okay, so we will be talking in depth about the pharyngeal arches and the reproductive system of the in the embryological portion of the reproductive system. Okay, where we have proper developmental structures coming from each and every arch. So for the purpose of neurology, let's focus on tongue right now. And for tongue, what we said is in this tongue you have the anterior one, and you have the anterior two-third. Okay, you have the anterior two-third, and you have the posterior one-third. You have the posterior one-third. Okay, you have the posterior one-third, and what's happening is the anterior two-third of the tongue, is developed from the first and from the second pharyngeal arch. Okay. The anterior two-third is developed from the first and the second pharyngeal arch, and the posterior posterior one-third over here. This is developed from the third and from the fourth. Okay. So the anterior, I'm not sure if you guys know, but the anterior an anterior two-third, which is developed from the first and second pharyngeal arch. The first pharyngeal arch is with involved with mandibular nerve, and the second pharyngeal arch is involved with the seventh cranial nerve. The seventh cranial nerve is basically the facial nerve. Okay, and what's happening over here is that the third and fourth are involved with CN9 and CN10, so vagus. Okay, so that's what it is. Okay, so first of all, if the anterior two-third of the tongue is developed from the first and second pharyngeal arch, and the posterior one-third is developed from the third and fourth pharyngeal arch. Okay, the first and second pharyngeal arch, the first arch is involved with the mandibular nerve, and the second pharyngeal arch is involved with the facial nerve. Okay, so what happens is you have so for the anterior two-third of the tongue, you have general sensations, and then you have taste sensations. Okay, taste sensations. So for the general sensations, that is the sensory. Okay, the sensory sensations or the general sensation that is carried by the mandibular division of the trigeminal nerve. Okay, and the taste sensations, which is a modified sensation, that modified sensation is carried by facial nerve or CN7. CN7. Okay, are we clear about the anterior two-third sensations? Before we move on to the posterior one, are we clear? Are we clear about the anterior two-third sensations of the tongue? Okay, the anterior two-third of the tongue. Okay, so once again, the anterior two-third is that the taste sensation is through which nerve? The taste sensation is through which nerve? Okay, good. And the general sensation is through which nerve? Okay. And then, okay, good. And from where is the anterior two-third of the tongue from where is the anterior two-third of the tongue developed from? Okay. And where is the posterior two-third of the tongue, I mean the posterior one-third of the tongue developed from? Three, four. Okay, correct. Okay, and now what's happening over here is for the posterior three-fourth, okay, we have the ninth and tenth cranial nerve. And the ninth cranial nerve, this one over here, okay, the ninth cranial nerve, for the posterior one-third, the ninth cranial nerve is important for carrying both taste and and your sensory sensation. So you have sensory and taste, both of which are being carried by the ninth cranial nerve. Okay, so both of which are being carried by the ninth cranial nerve. So next time when you receive questions about the tongue, and if they ask you uh, which one of what are the nerves that are involved for carrying the general sensations, the nerves are V3 and CN9. Okay, and which one of the nerves are important for carrying the taste sensations? Yeah, your answer is CN7 or facial nerve, or CN9 once again, because the CN9 is important for carrying both taste and your general sensations. And you have, if you have the extreme posterior, the extreme posterior, meaning the portion behind the posterior one third, that sensation is carried by the CN10. That sensation is carried by CN10. Okay, so do we have any confusion about the sensations of the tongue before we move forward? Okay. Okay, yes, we have confusion, or no, we do not have confusion. We have one student who said yes. Okay, so do you have any confusion, Dr. MS? Okay, no confusion. Repeat, please. Okay, so I will repeat it once again. So first of all, once again, okay, the tongue. The tongue is divided into an anterior two-third and posterior one-third. Okay, anterior two-third is developed from the first and second pharyngeal arch. Posterior one-third is developed from the third and fourth pharyngeal arch. Okay, and from the first arch we have V3. From the second arch we have CN7. V3 is responsible for general sensations, meaning that let's say you bite your tongue, you bite your tongue, okay, and now you have extreme pain sensations in your anterior two-third of the tongue. What is the nerve that is involved for carrying that pain sensation? It's V3. Okay, let's say now you are eating pizza. Okay, how are you enjoying your pizza? With the help of which nerve? That is through CN7, the anterior two-third. From the posterior one-third, you have only one nerve, so you have, which is CN9. Okay, CN9 is involved for both taste and your sensory or general sensation. So let's say if you have any general sensations over here, let's say you have, for some reason, posterior one third is very important for, let's say, a piece of hair. Okay, let's say a strand of hair is is present in the posterior one third. Okay, this strand of hair, what they would do is they would go and activate the CN9, and the CN9 would have your sensory sensations. At the same time, if you are eating something and that food is trying to provide your taste sensation, then the CN9 is once again involved for carrying that taste sensation. So the nerves that are involved for sensories are V3, 7, and CN9. That's all we talked about. Is that clear? Are we clear now? Okay, perfect. Okay, next are the okay, next are the motor innervations. Okay, next is the motor innervation. Okay, so the motor innervation is basically, before we talked about the motor innervation, let's talk about the muscles. So the first muscle that we have is hyoglossus. Okay, hyoglossus. Hyoglossus, what this does is the hyoglossus, let's say if this is the mouth, the hyoglossus will retract and depress the tongue. Okay, so retraction. So if you try to get your tongue back, and then if you try to get your tongue back, and then if you try to put your tongue down, okay, the muscle that is involved is hyoglossus. Okay, And then right now, let's say if you try to stick your tongue out, okay, if you try to stick your tongue out, the muscle that is involved is genioglossus. The muscle that is involved is genioglossus. So once again, if you try to stick your tongue inside and retract your tongue, the muscle that is involved is hyoglossus. And if you try to stick your tongue out, the muscle that is involved is genioglossus. And right now, let's say this is your mouth and you try to move your tongue from one side, okay, and you try to move your tongue to another side, okay, the muscle that is involved is styloglossus. Styloglossus, okay. I'm not sure if any one of the students are trying to do this by themselves, okay, trying to stick their tongue out, move their tongue from side to side. If you are, good job, okay. So you are putting your theoretical knowledge um, into your practical presentations. Okay. So once again, if you retract your tongue, hyoglossus. If you stick your tongue out, genioglossus. Okay. And then if you move your tongue from side to side, the muscle that is involved is styloglossus. Okay. So next time when you try to imitate someone, okay, next time you try to imitate someone, okay, or try to piss someone off, maybe you have a little brother at home or whoever, okay, you try to realize which muscles are being used for your movements, okay, which muscles are being used for your movements. So that's that, okay. Okay, now what is okay, so did everyone understand all the muscles that are involved with the movement of the tongue? Is the camera on? Okay, if oh, okay, all right, so that's what it is. These are the muscles that are involved with the movement of the tongue. Now let's talk about the nerve supply. The nerve supply of these muscles are very easy to understand. Okay, all of these nerves that we talked about. Okay, all of these nerves that we talked about are supplied by 12th cranial nerve. Okay, what is the name of the 12th cranial nerve? What is the name of the 12th cranial nerve? Okay, perfect. So all of them are supplied by the hypoglossal nerve or the 12th cranial nerve. And the only muscle that is not supplied by 12th cranial nerve is palatoglossus. Palatoglossus, okay, palatoglossus. And palatoglossus, this muscle over here, this palatoglossus muscle, this muscle is involved for swallowing. Okay, this helps. This is a posterior muscle. This stays posteriorly, and what this muscle does is this helps with proper swallowing. And this muscle is supplied by 10th cranial nerve, right? 10th cranial nerve. So we have all the informations of the tongue concised in one picture. So let me do a quick revision. First of all, the tongue. Okay, so we have the anterior two-third of the tongue, which is developed from the first and second pharyngeal arch, and then we have the posterior one-third of the tongue, which is developed from the third and fourth pharyngeal arch. The nerve supply of the first and second pharyngeal arch is V3 for first and facial nerve for second. Okay, and the nerve supply for the posterior one-third is CN9. Now, once again, the general sensation of the anterior two-third is carried by V3, and taste is by CN7, and the posterior one is carried by CN9. Okay, that's all. The muscles that are involved are hyoglossus, which moves, which retracts and which retracts and depresses the tongue, genioglossus, which sticks out the tongue like this, and then styloglossus, movement from side to side. And then we have palatoglossus, which helps in swallowing, and that is supplied by CN9, CN10, okay, and all the other muscles are supplied by CN12. All the other muscles are supplied by CN12. Okay, so did everyone understand all the information about the tongue? Okay, can I get one student who can answer the questions about the tongue? After that, we can take our break. Okay, who else? Do do we have anyone else? Another student? Okay. Can you guys hear my voice? Okay. So in first aid, they include C10 and taste and pain and in pain. Okay. Okay. So what's happening in over here is once again, I'm not sure which one you were referring to. Okay, let's go back to our text. Let's see if we have missed out on anything. Okay. I don't know why this is not working. Okay, let's come back. Okay, let's ask the question first, and then we will address your situation, your problem, or the thing. Okay. Okay, let's first ask or solidify the information that we have just studied over here while we give this some time to come. Okay. Okay, so who was the student who wanted to answer the questions about the tongue? Do we have any student who wanted to answer the questions about the tongue? Is there anyone who is interested in doing active participation? No problem. Okay, so let's ask Dr. Maheshwari over here. That's where you are.
Hello, doctor.
Okay, perfect. So what is, so where is the anterior two-third of the tongue developed from, please?
First and second pharyngeal arches.
Okay, and from the, and where is the posterior one-third developed from?
Third and fourth pharyngeal arches.
Okay, what is the taste sensation from the first anterior two-third? Which nerve is
Cranial nerve
involved?
7.
Oh, okay, perfect. Can we ask and the next student? The next student is Dr. Hussam. Thank you so much, Dr. Maheshwari, for performing. Okay, the next one is Dr. Hussam. Let's see where you are.
Yes, doctor.
Okay, perfect. Would you be kind enough to tell us which muscle is involved for moving the tongue side to side?
Styloglossus.
Okay, and which muscle is involved for moving the tongue posteriorly or protrudes the tongue?
Hypoglossus. Retraction
Okay,
and posteriorly.
retraction is by hypoglossus, and for protrusion.
Genioglossus.
Okay, genioglossus. Okay, which muscle is involved for swallowing?
For swallowing, palatoglossus.
Okay, perfect. Thank you so much. Okay, so if you guys can just remember these informations from the tongue, okay, you guys should be good. And that's what it is. Okay. So basically that's what it is. And if you guys are ready, then we can take that small break for that 10 minutes and then we can start with physiology. Is that okay? Okay. UWorld example of UWorld or USMLE is basically they will ask you questions directly from which part of the tongue is, or I mean, what is the nerve that is involved for carrying the taste sensations or the sensory sensations. Okay, which muscles are involved for movement of the tongue. Okay, what is the nerve supply of the muscles? As simple as that. And the nerve supplies of the muscles are once again all the muscles are supplied by hypoglossal nerve except palatoglossus, which is supplied by vagus nerve. Okay. Okay, you are welcome. Okay, so let's take that small break for 10 to 15 minutes and then we can come back and start with neurophysiology. Okay, so do we have everyone who's back from the break? Okay, so let's wait for 2 more minutes for everyone to come back. We only have two students who have written yes. Okay. Okay, so we have a question from Dr. User One about the recording lectures. Okay, so the issues which we are facing with the recording lectures are we are trying to upload them in our Google Drive. Okay, and what's happening is it's taking us a bit of some time. The reason being is because we are trying to make up the whole lectures from the first, so from lecture one all the way to lecture 21, so that it's easier for everyone to access the lectures as soon as possible. Once again, we apologize for this minor delay. I hope you would understand. Okay, but we are trying our best to get all the lectures out. Okay, so if you can provide us with a bit more time, we would be really, really grateful. Is that okay, Dr. User One? Okay, okay, perfect. So once again, I'm hoping that everyone is back from the break. And can anyone tell me the muscle innervations of the tongue? Okay, what are the muscles innervation of the tongue? Okay. What is the supply of palatoglossus? Perfect. Okay. 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 So let's move on to our second, to our next one over here. So this is neurology, anatomy, and physiology. Okay. For some reason, my my instructing page over here is not working. Okay, I'm trying to get this page out. So for that one, let's use this this page over here. Okay, so these are basically some very small knowledges which you need about all the cells of the nervous system. Okay, so for the first one, we have neurons, and we all know what neurons are. Neurons are basically the signal transmitting cells of the nervous system. Okay, so please use your markers to underline the questions of UWorld. Okay, so over here, what are basically neurons? Neurons are basically the signal transmitting cells. Okay, and the neurons, what they have is basically they have a dendrite. Okay, they have a dendrite, they have a cell body, and then they have an axon. Okay, and we all know the functions of all these the different types. I mean, all the different structures of the neurons. We know that the dendrites, they receive input. Okay, and then it travels all the way to the cell body, and then the cell bodies have axons, and after the cell bodies you have axons, and axons, what they do is they send output. So these are basic knowledges, mm, which you have from your previous knowledge of basic sciences, right? Okay. The important question for USMLE is they want to know that they want to know whether you can understand that you have a staining called the Nissl staining. Okay, so the Nissl staining, what they do is the Nissl staining is used to stain the neurons, and the cell bodies and the dendrites are highly filled with rough endoplasmic reticulum. Okay, so RER is rough endoplasmic reticulum, and the rough endoplasmic reticulum is an important organelle for your protein synthesis, right? And the rough endoplasmic reticulum is abundant in the cell body and in the dendrites. And whenever we use the Nissl staining to stain a neuron, this stain is highly um, highly abundant in the cell bodies and in the dendrites. And the question is, what is the reason for this high staining of the cell bodies and the dendrites? And your answer is your excess presence of rough endoplasmic reticulum. Okay, rough endoplasmic reticulum. So please write this down in your book, that you will get a question about Nissl staining. And when you get questions about Nissl staining, whenever they ask what will they stain, they will stain rough endoplasmic reticulum. Where will you find them? You will find them in the cell body and in the dendrites. Okay, did everyone write them down? Did everyone write them down? Okay. Okay, perfect. Okay, so keep in mind, I will ask you this question again. Okay, so next one are your astrocytes. Okay, so what are astrocytes? Astrocytes are basically glial cells. Does anyone know what a glial cell is? What do you mean by glial cells? What do you mean by glial cells? What is it? Supportive cells, okay, or cells which help in regeneration. Okay, so these are those glial cells. So the astrocytes are the most common type of regenerative and the supporting cells, known as the glial cells in the central nervous system. And what do? They are basically important for the support repair and also for extracellular potassium buffer. So what is this extracellular potassium buffer? We know that over here, okay, um, one second. We know that you have this entire neuron of cells, right? And what happens when you have this entire neuron of cells? You have these nerve transmission, that is the sodium potassium transmission along the entire neuron, okay? And these astrocytes have a lot of potassium buffers. So these potassium buffers, what they help in astrocyte doing is, what they help the astrocytes to do is they allow the astrocytes for proper signaling around the entire neurons. Okay, and that is basically what your extracellular potassium buffer means, meaning that if you need some excess potassium for your signal transmission, then your astrocytes are the one which contains a high amount of potassium. Okay, so that's that. You won't receive a lot of questions about this. The important question that you will receive is reactive gliosis is in response to neural injury, meaning that which of the cells are important for reactive gliosis, for reactive gliosis. What do you mean by reactive gliosis? Meaning that if you have a cellular injury at the nervous level, the cells which comes and proliferates at the beginning is the astrocyte. Because once again, we talked about the fact how the astrocytes are important for the proper structure and function, right? And regeneration of the nervous system, of the nervous cells. So the astrocytes are the primary cells which will come for reactive gliosis. Okay, reactive gliosis. So write them down. Which cell is important? So write this down. Which cell is important for the reactive gliosis? The cell that is important for reactive gliosis is astrocyte. Okay, and what is the astrocyte marker? Astrocyte marker is GFAP, and once again, GFAP is basically glial fibrillary. Okay, I'm not sure if you guys know the full form. Okay, so GFAP is basically glial fibrillary acidic protein. Okay, so this is a marker, and if you have GFAP positive, then this means that the cells that are positive are astrocytes. Okay, do we have any questions from astrocytes? Do we have any more questions from astrocytes? Okay, so these are really basic knowledges. If you can just read through, that's enough. Okay, so there's not much you need to understand. Okay, next one is basically microglia. What are microglia? Microglia are the macrophages of the central nervous system. Okay, so these are phagocytic scavengers, and they are activated in response to tissue damage. So if you have damage if you have damage to the neuronal structures, the cells that will come for reactive gliosis is astrocytes. Okay, and then if there is if there is phagocytosis, which is needed, then the cells that will come for phagocytosis are microglia. And once they come, what happens is if you have tissue damage, then you have if you have tissue damage, these cells, what they will do is when they have tissue damage, you have inflammatory mediators, right? And these inflammatory mediators, such as nitric oxide and glutamine, what they will do is they will come and they will activate the microglia. And once you have activation of the microglia can cause phagocytosis. As simple as that. Okay, and they are not stained by Nissl staining. Why are they not stained by Nissl staining? Can I get some answers? Why do you think these microglia are not stained by Nissl staining? Nissl staining is Nissl staining, right? There is no rough endoplasmic reticulum or lacking of a rough endoplasmic reticulum. Okay. And whenever you have a multi-nucleated giant cells, we know that the macrophages are important for the formation of the multi-nucleated giant cells, and the macrophage of the central nervous system is once again microglia. What is the name of the macrophage for the hepatic system? What is the name of the macrophage for the hepatic system? First, what is the name of the macrophage for the skin? Langerhans cells. Okay. What is the name of the macrophage for lungs? Lungs. Alveolar macrophage, that is correct. Alveolar macrophage. Okay. Next ones are ependymal cells. What are ependymal cells? Ependymal cells are, you have the ventricles. We talked about the ventricles before. Okay. We talked about the linings of the ventricle. Okay. We talked about the linings of the ventricle. So let's say if this is the ventricle, the ventricles are lined by these cells over here. Okay. And these cells are ciliated cells. Okay. These are ciliated and they are columnar cells. Okay, so these are ciliated and columnar cells. And what they do is you have this specialized ependymal cells. Okay, so ependymal cells, specialized ependymal cells, are known as choroid plexus. Okay, specialists. They are known as choroid plexus. Okay, and what is the function of choroid plexus? The function of choroid plexus is they secrete CSF. This is high yield. This is extremely high yield. So once again, if we have to break down the CSF drainage, okay, so you have choroid plexus, okay, which choroid plexus, what are choroid plexus? These are specialized ependymal cells. What are ependymal cells? Ependymal cells are the linings of the ventricles. They are simple ciliated columnar epithelial cells. And what do? They secrete CSF, okay, and the CSF then goes from the lateral ventricles to the third ventricle, then to the cerebral aqueduct. Once again, we're just doing a revision. Cerebral aqueduct, okay, from the cerebral aqueduct, they go to the fourth. From the fourth, they are released into the arachnoid spaces, and from there, they are absorbed by arachnoid granulations. And from the arachnoid granulations, they go to the dural venous sinuses. From the dural venous sinuses, they go to the superior vena cava. From the superior vena cava, they go to the heart. Okay, and then they circulate, and then they come all the way back to the choroid plexus. This is basically your CSF drainage system. Okay, very roughly put. So the question and concern is, what is choroid plexus? Choroid plexus is basically your specialized ependymal cells. Okay, specialized ependymal cells. Okay, so do we have any questions from these cells? Do we have any questions from these cells? Okay, perfect. Okay, so the next one which we will talk about is myelin. Okay, so what is myelin? Myelin, okay. So myelin is basically, okay, so what's happening with myelin is, let's do another quick review, is that if you have a neuron over here, okay, then myelins, okay, then these are myelins, okay. So myelins are basically the insulators, okay, they help in insulation of the neuronal vessels. Does anyone know the names of these nodes? What is the name of this node? in between the myelins? Very easy question. What is the name of this node? Nodes of Ranvier. Okay, these are known as nodes of Ranvier. Okay, and the importance of myelination is that the nerve stimulation. So you have sodium, potassium. Okay, so the sodium, potassium, and they help in nervous stimulation. So what's happening is these nodes are there are high concentrations, increased amount of high concentrations of sodium ions in these nodes. Okay, increased amount of sodium ions. And so what happens is in these conductions, when a nerve is myelinated or there is presence of myelin, there is jumping of conduction from the one node to another node to another node and then to another node. Okay, and what this does is this helps and speed up the transmission. If there was no myelination, for example, let's say if this is a neuron and there is no myelination, then there would have to be multiple small signal transmission and all the way, and this would result in overall signal transmission, which would be less because it would take a lot of time. It would take a long time for the signals to pass. But if the neurons are myelinated, then you have the presence of these nodes, which are high in sodium concentrations. And with the help of these nodes, you have these fast signal transmissions. Okay, so next time, if you hear about a myelinated nerve fiber, do you think about a fast transmission or a slow transmission? Do you think about fast transmission or slow transmission? Exactly. So you think about fast transmissions. Okay. Okay. And once again, you have two nervous systems. You have the central nervous system, and then you have the peripheral nervous system. The central nervous system is your brain and spinal cord, and the peripheral nervous systems are your peripheral nerves. And the nerves that are myelinated in the central, the myelination, the protein that is involved for myelination of the central nervous system, okay, that is synthesized from oligodendrocytes, from oligodendrocytes. Okay, and the protein that is important for myelination of the peripheral nervous system is developed from Schwann cells. Okay, Schwann cells. And this is extremely high yield, and you will receive a lot of questions about this in UWorld. Okay, I'm pretty sure you guys already know this. So next time, if they ask you what is used for the myelination of the nervous system, of the nerves and central nervous system, your answer should be oligodendrocytes. What is the protein that is used for the myelinations of the nerves in the peripheral nervous system? And your answer should be Schwann cells. Okay, Schwann cells. Okay, and that's that. Okay, let's see if we have covered everything from the text. Okay, so once again, these nerves are important for increasing the conduction of the velocity. And these conduction from one node to another, this conduction is known as saltatory conduction. These conduction is known as saltatory conduction. What's happening over here is the action potential are traveling from one node to another, and these nodes are high in sodium concentrations. Okay, and that's that. Okay, another one is you will get one question about what is the myelination, what is increase, what type of velocity is increasing with myelination. And with myelination, you have increased space constant. So you have these spaces, right? So you have myelination. Excuse me. Okay, my apologies. Okay, so you have these myelinations over here. Okay, and what's happening over here is you have these conductions occurring from one myelin to another myelin, and this is taking some space, and this constant space at which the velocity is traveling is known as increased space constant and increasing the conduction velocity. And that's exactly what's happening when the nerve is myelinated. Okay, when a nerve is myelinated. And do you think what's happening to the time constant? Okay, what's happening to the time constant? Is the time constant increased or decreased? Is the time constant myelination increased or decreased? Okay, that is, so what's happening over here, you have increased space constant, increased conduction velocity, and decreased time constant. Okay, and this is exactly vice versa to nerves that are not myelinated. So nerves that are not myelinated will have decreased space constant, decreased conduction velocity, and increased time constant. Is that in demyelinating? Yes, that is what happens in demyelination disorders. Okay, that is exactly what you will get in New World, and Dr. Tyne also already got this question in New World. So you would know that, we're not making the questions up once again. Okay. All right. Okay, next one. Next one is Schwann cells. Okay, Schwann cells. Okay, so what are Schwann cells? We talked about the fact how Schwann cells are important for the myelination of the peripheral nervous system. And the Schwann cells, what they are doing over here is that the Schwann cells, they promote axonal regeneration. Okay, and they promote axonal regeneration, and these cells are derived from the neural crest. Okay, so you will have neural crest derivatives in the embryology section of the reproductive structure, of the reproductive system. And over there, we will study about the fact how you have different derivatives from the different layers. Okay, and from over there, you can learn that the Schwann cells is derived from the neural crest. Okay, and one of the most important condition is known as GBS, or Guillain-Barré syndrome. Okay, in Guillain-Barré syndrome, what you have is you have this is an autoimmune disorders in which you have autoimmune destructions of the Schwann cells. Okay, and this is usually due to a microorganism. Do you guys know the name of the microorganism of Guillain-Barré syndrome? Campylobacter jejuni. That is correct. So the most high organism is Campylobacter jejuni, and for Campylobacter jejuni, there is a formation of this syndrome. Okay, this is a demyelinating disorder, inflammatory demyelinating disorder, and this is known as Guillain-Barré syndrome, and we will be talking about this in the future. And what are oligodendrocytes? Oligodendrocytes are the myelination cells for the central nervous system. Okay, and these are derived from the neuroectoderm too, and this is derived from the neural crest. Okay, this is derived from the neural crest, and this is derived from neuroectoderm. This is derived from neuroectoderm, and they have a fried egg appearance in histology, and we will be solidifying this information when we study about oligodendroglioma. We will be solidifying that information when we talk about oligodendroglioma. Okay, and there is a condition known as multiple sclerosis, one of the most important demyelinating disorder for USMLE step 1, which we will be studying in the neurovascular in the neuropathology. Okay, and in that pathology, we would be talking about the fact how there is demyelination of the myelin cells of the central nervous system, and we know that the myelination cells for the central nervous systems are oligodendrocytes, and loss of oligodendrocytes are extremely high yield for this pathology, that is multiple sclerosis. Okay. Okay. So not that important. Okay, just your knowledge about Schwann cells in peripheral nerve and oligodendrocyte in central nervous system. That's enough. Okay, that should be enough. Okay. So did everyone understand? Okay. All right. You guys just give me one quick second. Okay. Next one. This one is people had questions. Okay, my bad. I apologize. What were the questions of the people, please? Let me go back. Can you answer our question above? Okay. What is the question that you had? Time constant. What do you mean by that? Okay. Time constant. Time constant is what it is. Okay. Does anyone else have any other questions except their understanding of time constant? Anyone else? Any question except time constant? And Ranvier definition. Okay. And what else? Space constant. Okay. Okay. So we will be talking about time constant, space constant, and Ranvier definition. Anyone else? Any other question? Any other question from anyone else? Okay, so I guess no more questions. Okay, so what? Okay, and oligodendrocyte again. Okay, All right, so let's first talk about time constant, then we'll talk about space constant, then we will talk about um, nodes of Ranvier definition and oligodendrocyte. Okay, so first of all, what is time constant? Okay, so let's take another page over here. Give me one quick second. Okay. Okay, so let's say that this is a neuron which is not myelinated. Okay, this is a neuron which is not myelinated. Okay, and then you have sodium potassium transmissions. Okay, sodium potassium transmission that is occurring at every channel. Okay, at every channel. So you have sodium and potassium will going in, going out, and this is resulting in a signal transmission. Okay, so do you think that the time for this, okay, the time for this is increased or decreased? Increased or decreased? Why will the time be decreased? This will take more time, right? Because they're not skipping out on any parts. So the time constant, what is the time constant? Increase, that's correct. Okay, so no space. As a matter of fact, the time constant or the constant time at which the the nervous stimulation is taking place is increased. So the time constant is increased. Okay, next one. Next one is space constant. Okay, next one is space constant. Okay, so what's happening over here is the is the space constant over here is absolutely there is no space constant. Okay, so what's happening is you have you have you have this nervous stimulations that are occurring at different spaces. Okay, at different spaces over here. Okay, so if you have nervous stimulations that are occurring at different spaces, okay, if you have nervous stimulations that are occurring at different spaces over here, okay, and do you realize that the space in between these nervous stimulations are extremely small? Okay, so small spaces, they're happening in small spaces. So if they are happening in small spaces, is the space constant increased or decreased? Decreased, that is correct. Space constant is decreased. Okay, and what about the velocity of or the speed at which the nerve stimulation is taking place? Is the speed increased or decreased? Decreased, that is correct. Decreased speed. Okay, now let's talk about a nerve that is myelinated. Okay, okay. Before we do that, let's talk about the nodes of Ranvier, which were asked by Dr. Karbasi. Okay, so nodes of Ranvier are basically these nodes in between the myelination, in between the myelin cells, which are high in sodium. So if they're high in sodium, this is the part where signal transmission is not occurring. Okay, so the signal transmissions occur here at one node, and then they travel all the way to this other node. Why is this traveling all the way to this other node? Because this is important because these nodes have high sodium concentrations all the way. So they're high in sodium over here. So this helps in increasing the signal transmission. So for this one over here, okay, what is the time constant? Is the time constant decreased or increased? Is it taking more time or less time? Decreased, that is. So for this one, time constant is decreased. Okay, is the space increased over here or decreased? Space at which the signal transmission is occurring, is the space increased or decreased? Decreased. Okay, what's happening to the conduction velocity? Is it increased or decreased? Over here it was taking a lot of time, so the speed was less. What is happening to the conduction velocity over here? Increased, right? It's increased, so you have increased speed. Okay, that's it, that's all. Are you guys clear about time constant, space constant, and conduction velocity now? Do we have any more questions? Confusion? One? Okay. 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 I apologize for not looking at the questions before. Okay, because I was involved in. I got too involved in discussing. I should have addressed the questions. Okay. So my apologies. But if you ever have any questions, please ask them whenever you get the chance. I will try my best to give you the answers. Okay. And another question that was presented was, what are oligodendrocytes? Oligodendrocytes are basically cells which helps in myelination of the nerves in central nervous system. Done. Nothing else. Okay. Is that clear? Perfect. Okay. Okay. So if that is all, then we would like to move on. Okay. If any more questions, because I realize how hard neurology can be. Okay, so that is why I'm asking you guys, if you have any questions, please clear it out. Because if you move forward with confusion, you will keep on getting confused, and then this whole chapter will be extremely confused. Okay. Okay, no more questions. Perfect. Okay, let's go back to our text. Okay. Okay. And this table over here is extremely annoying. One of the most annoying tables that you will find in first aid, and this is the father of all annoying tables. Okay, because I mean, it's extremely difficult to recall all the information over here, but once again, I will try my best to break this thing down so that it's easy for you to understand this. Okay. And what I would do is, after we are done discussing this with the help of mnemonics, stories, or whatever, I would need you guys to recall and review this right away, so that I have understood that you guys have learned all the informations. Okay, so this is basically a table of sensory receptors. Okay, so we have sensory receptors such as free nerve endings, Meissner's corpuscle, Pacinian corpuscles, Merkel discs, and Ruffini's corpuscles. Okay, and these sensory receptors are important for different type of sensations. Okay, so we know that the sensory sensations can be divided into pain, temperature, then we have fine touch, then again we have fine touch, and then we have light. I mean, we have fine touch, and then we have dynamic touches, then we have vibrations and position sense, and then there are other sensations such as slippage of objects, meaning that if you have, let's say, an object, okay, which can slip along the surface of your skin or along the side of your skin. So the most proper example I can give you is, for example, let's say you are holding like a glass of water or something. I don't even know what I'm drawing over here. Okay, so let's say you are holding like a glass of water. Okay, and this is your arm. Okay, you are holding this glass of water. Okay, and if for some reason this glass of water is slippery and this slips off your hands, okay, and this slips off your hand, you will get a very fast stimulation. Okay, you will get a very fast stimulation, and this stimulation is known as slippage of object stimulation. Okay, so the slippage of object stimulation. Another type of stimulation, which is a sensory stimulation, is a joint angle change stimulation, meaning that every time you sit, every time you move your legs, or you position your legs in a certain positions, okay, in a certain position, it will send information from that joint all the way through the Ruffini corpuscles. Okay, that will allow you to identify what the position of your joint is. So these are the different type of sensations that we feel. Okay, and now what we will be doing is, how will you get questions in UWorld? You will get questions in UWorld where they will ask you, that you have a patient who has some sort of issues with, let's say, pain, and then they might ask you what is the nerve receptor that is damaged. Okay, and the nerve receptor that is damaged is, let's say, free nerve ending. So the questions and answers are inverted, like most of the ones that we have studied before. So if you have to really test yourself after you have understood this whole table, please cover this part of the table with your hand and try to answer from this part. So from here to here, try to answer, try to see whether you recall from here to here, instead of doing the usual covering this part of the table with your hand and doing from this side to this side. Okay, with that being said, let's start. The first thing that we'll be talking about is free nerve endings. Okay, free nerve endings can be divided into A delta, C, and C.
A delta and C. Okay, and free nerve endings have A delta fibers, which are extremely fast. Okay, these are fast, and A delta are fast. So if we have fast fibers, then we know that the nerves should be myelinated, right? Because we talked about the fact how myelination increases the space constant and conduction velocity. So fast fibers are myelinated, and A delta is a fast fibers, and C are slow, okay, and they are unmyelinated. So how can you remember this very effectively? Is if you can just, instead of doing all this, a delta plane is fast, but a taxi is slow. Just remember the word slow. Okay, CLOW, slow. Okay, just so you have gone weird from studying medicine, and now you have started pronouncing words which sounds like something, but it looks completely different. Okay, so why are you doing this? You are doing this because this helps you remember. Okay, so clo is basically C low, meaning, okay, so C fibers are slow, as simple as that. Okay, did you guys realize why I said what I said? Anyone? Okay, good. So it's just a mnemonic. Okay, it's just a mnemonic, nothing else. Okay, so slow. So CLOW, slow. Okay, and A delta fibers are fast. That's simple as that. Okay, and once again, if you have a slow fibers, they're unmyelinated, and A delta fibers are fast because they're myelinated. Okay, next. Next is pain. And the best part about free nerve endings is that they are present on all skin. So there is no differentiations of the skin in which you won't feel pain. Is there any part of your body where you will not feel pain? It's highly unlikely. Okay, so every part of your skin has abundance of free nerve endings. Okay, and what is the sensation? The sensation is pain and temperature. So I believe that free nerve endings are one of the most easiest sensory receptors to learn, okay, because free nerve endings are your pain and temperature receptors, and it's divided into A delta and C. And how did we use it? We used it because we have gone weird from studying medicine for too long, and we are pronouncing words which makes no sense. Okay, so so nowadays we pronounce slow as clo, CLOW. Okay, so CLOW. So CLOW are C fibers, which are slow. If C fibers are slow, then obviously your A delta fiber should be fast. As simple as that. Okay, and all of this is because you will receive questions in your UWorld regarding the fast and slow fibers. Okay, next one. Next one is Meissner's corpuscle. Okay, Meissner's corpuscle. Okay, do you guys know the famous player Messi, Lionel Messi? Yeah, no. Okay, good. Okay. Does Messi have hair or no hair? Fine hair, right? Does Messi have fine hair? Hair, yes. Okay. But over here, our Messi is hairless. Okay. Okay. Why is Messi hairless? So write this down in your book. Messi is hairless. Okay. So Meissner's corpuscle. More often than none, you will receive questions about the fact of which about where the Meissner's corpuscles are located, and the Meissner's corpuscles are located on the hairless skin. So Messi is hairless, and Messi is hairless, and is Messi dynamic? Is Messi a dynamic player? Is Messi a dynamic player? Yes, he is. Is he a fine player? Yes, he is. So what is Messi? Messi is hairless. Okay, but he is dynamic, and Messi is hairless, but he is dynamic and fine, meaning that our Messi over here, okay, which is Meissner's corpuscles, okay, they are present on hairless skin, and they can detect dynamic and fine touch sensations. Okay, they can also detect position sense and low frequency vibrations. And these are not very high yield. The highest yield are fine touch and dynamic touches. And the sensory receptor that is important for fine and dynamic touch is Meissner's corpuscle, or Messi. Okay, and Another thing that you have to realize about Meissner's corpuscles are, since they can detect fine touch. Okay, fine touch is a very very specific type of sensations, and for in order for receptors to send impulses for these sensations, they have to be myelinated, right? And if they are myelinated fibers can adapt really quickly. Okay, these myelinated fibers, they adapt quickly, except Merkel disc, which adapts slowly. What is adaptation? Adaptation is basically adaptations of the, meaning that the ability of the receptors, okay, meaning that the ability of the receptors to send out impulses very quickly. Okay, so whenever you get fine touch, let's say you are um, dynamics. Okay, so basically what is a dynamic sense and what is a fine sense? Okay, so dynamic sense is, let's say, okay, so let's say this is your hand. Okay, okay, if there is a, if you place, a big ball, okay, if you place a big ball, does it send a sensation, yes or no, that you have a ball on your hand? Does it send a sensation, yes or no, Dr. Nadine? Okay, good. So it does send a sensation, right? And this sensation, which is covering the whole part of your hand, okay, it is not specific. Okay, it's covering the whole part of your hand, and this sensation over here could be an example of a dynamic sense. Now, if you have your hand over here, okay, and over here you are being pricked by a needle, by a very fine needle, okay, and this fine needle pricking, or this fine needle sensation, this sensation is known as a fine touch. Is that clear? Crude touch, yes. Okay, are we clear? Okay, okay, good. All right, so that's what it is. Basically, that you have your, where were we? We have, right, we were in Messi, right? So once again, Messi is hairless, and but he is dynamic and fine, meaning that he is, meaning that Meissner's corpuscles can detect dynamic touch and fine touch. Okay, and where are they present? They are present in hairless skin because Messi is hairless. Okay. Okay, next one. Next one is Pacinian corpuscle. Next one is Pacinian's corpuscle. Have you guys played the game Pac-Man? Did you guys ever play the game Pac-Man? Okay. So for this one, Pacinian corpuscle is our Pac-Man. Okay, so what? Okay. So if you have not played the game Pac-Man, Pac-Man is basically a type of game which is an arcade game. Okay, so you can Google that game out when you get the chance. But Pac-Man is basically a game, and Pac-Man is our mnemonic for Pacinian corpuscle. And Pac-Man is fast, wears a cap, and vibrates on pressure. Okay, so please write this mnemonic down. Pac-Man is fast, okay, meaning that Pac-Mans are myelinated fibers, okay. And Pac-Mans, they wear a cap, okay. By cap, we mean joints, okay, because we know joints are capped, okay. So we have capping of the joints, right? So Pac-Mans are fast, wears a cap, they are present in joints and ligaments, and they vibrate on pressure. And if you put pressure on a Pac-Man, they will start vibrating, meaning that they are used for detecting high frequency vibration and pressure. High frequency vibration and pressure. Okay, so guys, write that mnemonic down. Pac-Man is fast, meaning that Pac-Mans are myelinated. Then Pac-Man wears a cap, and we know that joints are capped. Okay, joints are capped by either another bones, or they have cappings by synovial fluids, right? So joints are capped, and they vibrate on pressure. Okay, so they are used for detecting high frequency vibration and pressure. And if Pac-Man is used for high frequency vibration, if they ever ask which of the receptors are used for low frequency vibration, and for low frequency vibrations, you have Meissner's corpuscles. Okay, so that's that. Okay. Did everyone write down the mnemonic? Okay, good. Okay, good. Okay. Okay. Next one. Next one is one second, please. Okay. Next one. Next one. Okay. Make PPT slow on fingers and skin. Okay. So the next one is your mnemonic. Make PPT slow on fingers and skin. Okay. So make is your mnemonic for Merkel discs. Okay. Once again, your Merkel discs and Ruffini corpuscles are not very high yield sensory receptors. Okay, so we have covered the three most important sensory receptors. That is these ones over here. These are more high yield. So these will be 2 stars. Okay, this could easily be 1 star. Okay, the next one will do. So make PPT slow. Make PPT slow on fingers and skin. And what is PPT? PPT is pressure, position, position sense, and deep touch. So pressure, position sense, and deep touch. And we apologize that we could not come up with a better mnemonic for this. Okay, but this is what we have. This is what we used for our understanding of Merkel's disc. So what is basically Merkel disc? These are basically sensory receptors that are present on myelinated. These are basically receptors that are present on fingertips and superficial skin. Okay, and what they do is these are usually used for detecting the position sense, meaning that you have information that is going to your cerebellum every second, right? Every second or millisecond about the different position that your joint is in. Okay, it's even without your understanding that your cerebellum knows that where your fingers or your leg is placed. If you are sitting on a table right now, even if you cannot see your leg, you know exactly where your leg is positioned. Okay, and that sensation, that example of once again, if you're sitting on a table and you cannot see your leg, right, you can still understand at which position or at which or at which place your leg is placed, right? And that sensation is covered by Merkel discs, okay? And these are myelinated fibers, okay? But the problem is they adapt slowly, okay? So they adapt slowly, meaning that it takes them at least some time to understand what the position of the joint is, and then they send that impulse all the way to the higher centers, okay? And um, this is known as this is known as this receptor is known as the Merkel discs. So once again, make PPT slow on fingers and skin. So make for Merkel discs, PPT for pressure, position sense, and touch, slow for the fact that it adopts slowly, and fingers and skin for fingertips and superficial skin. Okay, fingertips and superficial skin. Okay. Do you guys understand? You guys write down the mnemonic? Okay. Next one. Next one. Next one is my finger. Okay. My fingertips and joints are not rough. They are smooth, so that objects can slip. Okay, this is a big one over here. So this is a big mnemonic that we have used for a very little function of Ruffini's corpuscle. So basically, Ruffini corpuscle, once again, is that it's the sensory receptor that is used for detecting mainly the slippage of objects from the surface of the skin. Okay, and where are they present? They are present basically at the fingertips, so the tips of the finger. Okay, and some of them are also present at the joints. Okay, but they're more high yield for the fingertips than they are for the joints. So Ruffini corpuscles are the fact that my fingertips and joints for the location are not rough for Ruffini corpuscles. They are smooth so that objects can slip. So slippage of objects. Okay, slippage of objects, and that's all you have to know about the sensory receptors of the body. Did you guys write down the mnemonic? Okay. Okay, so does that help you guys, or does this make the whole thing even more confusing? Because we are ready to go for another approach if it is. Okay, so next time what you have to do is just try to remember all the mnemonics. And if you remember the mnemonics, hopefully in the exam you can recall all the information, because it's extremely difficult to recall this information just from purely reading it over and over and over again. Okay, so these mnemonics, hopefully what they will do is they will allow you to read it once and then you can recall it right away. Let's do a revision. After that, I will ask some of the doctors over here to see whether they have understood. Once again, free nerve endings have no mnemonics. The only mnemonic that we have used is CELO. Okay, CELO is what we are using to pronounce slow. Okay, why are we doing that? Okay, because we have lost our minds. Okay, so now we are pronouncing CELO as slow. Okay, and this helps us remember that C is important for slow transmission. And obviously, if C is for slow, then A delta is for fast. And free nerve endings are pain and temperature receptors, and they are present on all skins. Okay, next one. Next one is Messi is hairless, but he is dynamic and fine, for the fact that mucinous corpuscles are present on hairless skin, and they help us identify dynamic and fine touches. Okay, and obviously, if that's what it is, then for fine touch, we know that they would have to adapt quickly. And so they're myelinated fibers and they adapt quickly. Okay, next one. Next one is Pac-Man is fast, for fast fibers. Pac-Man is fast wears a cap for the fact that they are present on joints, that all the joints are capped by either bones or synovial fluid, and they vibrate on pressure. So high frequency vibration and pressure detection. Okay, next one is make PPT slow on fingers and skin. So make for Merkel's discs, PPT for pressure, position, and touch on finger and skin for the location that is fingers and superficial skin. And Ruffini corpuscles for my fingertips and joints are not rough. So fingertips and joints have Ruffini corpuscles. Okay, rough for Ruffini corpuscles. They are smooth, so objects can slip. Okay, smooth, so objects can slip for slippage of objects. Okay, so now hopefully I would need the participations of let's say 3 physicians or 3 doctors over here who can help me realize that every one of you have understood the information that we have just put for you. So I will give you guys 1 minute. Okay, I will give you guys 1 minute. So please try to recall the information right away. Why do we do this? It's because we want you guys to master the information of a first aid right away so that the rest of the day can be used for solving your world question. Okay. Okay, so 1 minute starts now. If anyone is done, please let me know. Okay, do we have anyone else? Dr. Hassan, as usual, thank you. Okay. And we have another doctor over here, Dr. Maheshwari. Okay. So let's start with Dr. Tari. Let's see where you are. Okay. Okay, perfect. So can you hear my voice?
Yes.
Okay, perfect. Would you be kind enough to tell us? Please don't look at the screen. Okay. So first of all, don't look at the screen. See if you have understood the knowledge. Okay. So first of all, would you be kind enough to tell us all that you know about Meissner's corpuscles from the mnemonic, starting with the mnemonic?
Okay, so Meissner's corpuscles, the mnemonic was he's hairless. No, he's messy. Meissner, I guess you named him messy, is
Right.
hairless, but he's dynamic and fine.
Perfect. Perfect.
So hairless for, I guess, the skin that has no hair. That's where you find them.
Okay.
And then there's dynamic and fine touch.
Okay. Perfect. Okay, good. Would you be kind enough to tell us all the information you know about Ruffini corpuscles?
Um, Ruffini's first. Okay, so the mnemonic is the fingers and the joints are not rough; they're actually slippery. So for slippage, um, it's usually for slippage and angle changes in the joints.
Okay, and what are the locations of Ruffini corpuscles once again?
On the tips of your fingers and joints.
Joints, and they are used for sensing the slippage of objects. That's all you need to know. So thank you so much for
Okay.
waiting. Next one is Dr. Hussam, our friendly doctor, Dr. Hussam. Thank you so much once again, who is always present for participation.
Yes, doctor.
Okay, so would you be kind enough to tell us what are the informations you know about Pacinian corpuscles?
Yeah, so our mnemonic is Pac-Man is fast, wearing
Mhm.
cap, and move on vibration, something like that.
Vibration pressure.
So
That's correct. Okay.
yeah, vibration and pressure.
Okay. So what are
So
the locations of Pacinian corpuscles?
in deep layers and joints.
Joints and ligaments. That is correct. And what are the
Yeah.
senses? Well, what are the senses?
Pressure and high frequency vibration.
Perfect. Okay. And what are the informations you know about free nerve endings?
So basically, free nerve ending, we have two types, low and low.
Okay.
It detects temperature, pain,
Okay. What are
and
the
it presents over the wall skin,
okay? Which one of them is the fast fiber, A delta or C?
A delta, because C is slow.
Perfect, perfect. Thank you so much. Can we have the
So
next doctor? The next doctor is, I believe, Dr. Maheshwari over here.
Yes, doctor.
Perfect. Which one did we leave out? Free nerve ending, Pacinian, we did Messner's, we did. Okay, so what are the informations you know about Merkel discs?
The mnemonic is make PPTs on fingers and skin.
Okay, make
So it is
PPT
located
on
slow on
fingers and
fingers and skin. Yeah.
okay. So what are the senses of Merkel discs?
It is high frequency. It is pressure and position sense.
Pressure, position sense, and deep static touch or touch. Okay, good, very good.
Yes.
What are the locations of Merkel discs?
Fingertips and superficial skin.
Okay, are they do they adapt slowly or do they adapt fast?
Slowly.
Perfect. Thank you so much for participating. That's what it is. Okay, so hopefully all the other doctors have heard and hopefully they have also understood. Okay, do we have any concerns, questions, or concerns regarding the sensory receptors? Regarding the sensory receptors. Do you have any other questions or concerns regarding the sensory receptors? Okay, please do not ask me how you will receive questions about sensory receptors, okay, because I am absolutely not sure, because I have received questions about this in various ways, okay. So examples would be an example, let's say they can ask for the name of the receptors that is present on hairless skin, and the name is Meissner's. they can directly ask you what is the senses that Meissner's corpuscles detect, and these are the senses. So they can go from here to here, from here to here. But usually what they do is, on most cases, they try to ask you the names of the sensory receptors. So the best thing to do for sensory receptor table is to learn all the information. And the easiest way you can do that is just by the mnemonics that we have used. Okay. Okay. The most famous question that I know is, which are among them damaged in DM? Okay, so what is your answer? Which one of them is damaged in DM? Unfortunately, we have not received a question like that. Okay, okay, corpuscle makes sense. Pacinian corpuscles could be damaged in high frequency vibration and pressure changes. So basically, that's not the question and concern for diabetic mellitus. For diabetes mellitus, questions are basically, do you guys have any idea which one of the following layers of the nervous systems are damaged in diabetes mellitus? Okay, so we have the outer layer and the inner layer of the nerves. Which one of them are damaged more, the outer or the inner? We will talk about this in the future, not today. Inner, that is correct. Okay, inner layers are more damaged in, okay, diabetes mellitus. Okay, all right, so should we move on? Do we have any concerns? Should we move on? Do we move on? Okay. Okay, perfect. Okay, all right. So let's talk about the next nerves. Okay, so let's talk about the peripheral nerve. The peripheral nerves have basically nerve fibers. Okay, as you can see over here, these nerve fibers are covered by a layer that is known as endoneurium, and endoneurium, okay, is once again covered by perineurium. Perineurium is once again covered by epineurium, and epineurium is covered by and a collection of an epineurium is basically a collection of nerve fibers. Okay, and that's basically what you have to know. You will not receive a lot of questions from this in your exam, but if you have to receive a question from this, which one of this is the dense connective tissue, and the dense connective tissue is the epineurium, and this is basically a very easy thing to identify, because the epineurium is they connect all the nerve fibers together. So that is basically your dense connective tissue. Okay, next one. Next one is, what is chromatolysis? Okay, this is important. So what is chromatolysis? Chromatolysis is basically your reaction of neuronal cell body to axonal injury. So once again, if you have an axonal injury, let's say you have a nerve damage, what are the processes that are occurring? And that process is known as chromatolysis. Do we have another doctor over here, Dr. Hassan from, oh, okay, we have Dr. Hassan over here. Okay, just to make sure if you received the Zoom link or not. Okay, good. So what's happening over here is so you have so the process of chromatolysis is basically the reaction that is occurring after neuronal cell body damage. Okay, and what's happening is you have increased protein synthesis. When you have nerve damage, you have increased protein synthesis, which increases in an effort to repair the damaged axon. And these are basically very easy text and sentences to understand, obviously, because your nerves are made up of proteins. And if you have damage of the nerves, your protein synthesis will increase. Okay, so what is the process of chromatolysis? First of all, you have round cellular swelling. Okay, so you have cellular swelling over here. So, and before looking at this picture, let's look at this picture first. So this is the first step. First step is you have round cellular swelling. And what is this round cellular swelling representing? So when there is injury, first of all, you have this cellular swelling, which is a sign of reversible or irreversible cellular swelling. It's a sign of reversible or irreversible injury, reversible. So reversible. So you have cellular swelling, and when you have cellular swelling in chromatolysis, the nucleus, which should have been in the center, this gets moved all the way. This gets moved all the way to the periphery. Okay, so first the nucleus is moved to the periphery, and then there is presence of high amount of these things over here, these dots. Okay, what are these dots? These dots are basically your representations of RER. RER is basically rough endoplasmic reticulum. Okay, so that's what's happening. Okay, after that, after cellular swelling, what you have is you have an axonal retraction. So this is the site of the damage. So from the site of the damage, what you basically have is this part of the axon, which retracts or goes back. Why does it retract or go back? Because this is a primitive mechanism which is endured by the nerve, which the nerve tries to protect itself or protects the previous that part that is not damaged. Okay, so through this primitive mechanism, what this does is through the help of contractile filaments, this nerve, it retracts back. Okay, and from the retraction of so if there is damage at this part, okay, and this part is retracting, this is the part which undergoes degeneration. And what helps in degeneration, then the cell that is involved for degeneration is microglia. Microglia are basically your phagocytic scavengers of the nervous system. The macroglia is basically your phagocytic scavengers of the central nervous system. And the macroglia, what it helps is, it helps remove all the debris. So we have the myelin debris. And this process of removal of the debris is known as Wallerian degeneration. Okay, so what are the steps of chromatolysis? The steps of chromatolysis are actually these steps. Okay, and these steps are really important because you will be receiving questions in NBME. Chromatolysis questions are very important for NBME. NBME wants you to know whether you have understood all the 3 steps of chromatolysis. So what are the 3 steps of chromatolysis? Once again, can I get some fast answers? What is the number 1 step? About a lot I received about this. Okay, so you have been doing a lot of NBME questions. Thank you so much. Okay, good. So first of all, the first step is cellular swing. Very good by Dr. Okay. Okay, next one. What is the next step? Next step is peripheral positioning of the nucleus. Okay, and then what the step? The next step is the last step. What is the last step of chromatolysis? Increased in rough endoplasmic reticulum or dispersion of nasal substance, perfectly put. So that's what's happening. Then after that you have axonal retraction. Okay, and then after you have Wallerian degeneration. Okay, that's what it is. And after this part is removed, what happens is the cell body, this helps protrudes a new nerve. Okay, this helps protrude a new nerve, and then they try to, what they do is they try to form a new axon. Okay, and then they try to complete the nerve which has been damaged. Okay, and this whole process is known as nerve regeneration. Okay, so nerve regeneration, how many steps does nerve regeneration have? Nerve regeneration has 3 steps. What are the 3 steps? The first step is chromatolysis. The second step is axonal retraction. The third step is Wallerian degeneration. What is chromatolysis? This is a reversible cell injury in which there is swelling, dispersion of the displacement of the nucleus to the periphery, and increase in rough endoplasmic reticulum. The next step is retraction of the axons to prevent further damage. And the third step is removal of the debris by the microglia, which is known as Wallerian degeneration. Okay, which is known as Wallerian degeneration. Okay, so is everyone clear about nerve regeneration? Reversible. Cellular swelling is a sign of reversible cell injury. Any more questions? Do we have any more questions? Reversible injury usually decreases protein. Okay, so what is your question once again? I'm not. Be sure that once again, is cellular swelling a reversible injury or a irreversible injury? And I will break this down for you right now. Can I get some fast answers? Reversible. Why is cellular swelling occurring? Why is cellular swelling occurring? Right. So there is disruption of the sodium potassium ATPase pumps at the cell membrane, and due to the disruption of the sodium potassium ATPase pumps, you have swelling of the cells, right? And what this does is when you have cellular swelling, you have rough endoplasmic reticulum. Okay, you have rough endoplasmic reticulum, which is there new formation of rough endoplasmic reticulum or breakdown of rough endoplasmic reticulum? New formation or breakdown. Okay, there is breakdown. With the breakdown of rough endoplasmic reticulum, is there increased in the segments of rough endoplasmic reticulum or decrease in the segments of rough endoplasmic reticulum? Do we have more segments or less segments? More segments. If we have more segments of the rough endoplasmic reticulum, will there be increased dispersion of nasal substance or decreased dispersion of nasal substance? Okay. And will this result in increased protein synthesis or decreased protein synthesis?
Excuse
Excuse me, what was that? Decreased protein synthesis. Okay. Okay. So is that clear now, Dr. Dawood or Hazam? Are we clear now? Dr. Hazam, Dr. Naud, your questions, are they answered now? More questions? That question, okay, what was your question? Oh, I don't know. Oh, okay, my bad, I'm sorry.
Okay, you hear me?
Okay, yes. We have
Yeah.
Dr. Adam over here. Okay, so what is your question, doctor?
Yeah, my question is usually in reversible cell injury,
Mm-hmm.
there is cell swelling and detachment of the ribosomes from the rough endoplasmic reticulum.
Perfect.
Therefore, this will usually result in decreased protein synthesis.
Okay.
But in this case, it is saying increased protein synthesis, and we are saying it is reversible cell injury.
Oh, okay, perfect. Okay, now I understand. Okay, okay. So first of all, what's happening over here is okay. So 1 second, can you hear my voice, Dr. Adhanom?
Yes, yeah.
Okay, perfect. Okay, so what's happening over here is, first of all, let's break it down from the get-go. Okay, so first of all, what's happening is for the regeneration to occur, overall, you need the regeneration to occur because you need to have increased protein synthesis, right? But the increased protein synthesis is not occurring over here. Do you realize this? Because there is dispersion of the increased protein synthesis is occurring at the distal segment, not the proximal segment. This is the proximal segment. This is the distal segment. The distal segment is being this is being broken down into debris, and this debris is being phagocytosed by the microglia, right? And this segment over here, this segment in which there should have been increased amount of rough endoplasmic reticulum, over now what's happening is, since you have reversible injury, exactly what you said is happening over here, that there is detachment of the ribosomes and breakage of the rough endoplasmic reticulum. That's why you have increased dispersion of the nasal substances. And so the protein synthesis over here is decreased, but the protein synthesis over here has to be increased. But this increase in protein synthesis occurs in the distal segment, not in this segment.
Okay, thank you. Yeah.
Okay, so any more confusion? Any more confusion? Any more questions? Before we move forward to our second annoying table. Okay, what is your question? Okay, anyone else? Please, I would love to clear all the confusions out so that we can move forward, because neurology can be pretty confusing. Anyone else? Any question? Any question? Do we need such details? It makes things more confusing. No, we do not need these details. We do not need to understand these details, okay? But if you want to, it's my job to make you understand everything that you have confusion, Okay, but for the purpose of your exam, if you can understand the steps of chromatolysis, that's enough. Okay. Okay. So what is your question, Dr. Tarian, and how can we address your confusion?
I don't know. I just kind of got confused with the whole proteins increasing and
Okay,
decreasing.
perfect.
Is that
Let me break it down. Okay, you know what? You go ahead. Let's hear your question first. I apologize.
yeah, no, it was just something about like the proteins increasing and decreasing. So that kind of like confused
Okay.
me. So I'm not sure like what's
Okay,
happening.
perfect. So let me address that part once again. Okay. So let's skip out on this text. Let's go back to our diagram. Let's see if I can. Okay, give me 1 second. Okay. So what's happening over here is, first of all, you have a nerve damage. Okay. So let's say you have a nerve damage. After you have a nerve damage, what's happening is the first step that is occurring after nerve damage is chromatolysis. Okay. So what's happening with chromatolysis? Chromatolysis is basically your reversible cell injury. Okay, and what's happening in reversible cell injuries are the processes which have been described perfectly by Dr. Adhanom, which is cellular injury, I mean your cellular swelling, okay, and then you have detachment of the ribosomes, and then there is pushing of the nucleus to the periphery, okay, and then the rough endoplasmic reticulum, they break down. Okay, so there's broken down of rough endoplasmic reticulum, and all of this, what's happening is over here you have decreased, as a result, you have decreased protein synthesis in the cell body. Okay, and then you have this part. Okay, so we're done with chromatolysis, and that's exactly what's happening in chromatolysis. And then we have the next part. The next part is basically your axonal retraction. Okay, so the next part is axonal retraction, in which this is a primitive reflex of the axons to retract to prevent further damage. Done. The third part about what's happening is the part that is injured, it has been formed into a debris that is phagocytosed, okay, by the microglia, and this has been removed. And once this debris is removed, this part, this distal segment, has to increase in protein synthesis. Why? Because if it does not increase in protein synthesis, how can it protrude or form a new growth or sprout of a nervous protrusion? So in order for that protrusion to occur, the thing that is happening is increased protein synthesis. So what first aid did was they mentioned increase in protein synthesis, but they did not specifically specify where the location of the protein synthesis is occurring. It's not occurring in, yes, it's not occurring during chromatolysis. It's occurring during regeneration. Okay, regeneration requires increase in protein synthesis. Okay. Okay, perfect. Okay. Once again, for the purpose of your exam, what you have to understand is you have to understand the steps of chromatolysis. Okay. And then you have to understand that regeneration requires 3 steps: chromatolysis, axonal retraction, and Wallerian degeneration. Okay. And then axonal regeneration. Okay. Okay. Okay, round cellular swelling because of detachment of ribosomes. No, cellular swelling is because of disruption of the membrane channel proteins. Okay, cellular swelling is due to the disruption of the membrane channel proteins. Okay. Okay. Any more questions? Any more questions before we move on to the next table? Okay. Okay, so are you guys ready to address the next annoying table for your neurotransmitters over here? Although this one I find less annoying than the sensory receptors, but equally annoying because you have to do baseless memorizations. Okay, so that's that. Is everyone ready? Clear-headed? Relieved of all confusions to move? Okay, perfect. Okay, so let's start with our second group of next for the neurotransmitters. And once again, extremely annoying. Why is this annoying? Because you have to do less understanding and more memorizations. Okay, and for some people that's fun. For others, that's not. Okay, and for me, it's not fun. Okay, but the best part is we have come up with mnemonics that will help you. So before we address what are the what happens to the neurotransmitters in the diseases, that is anxiety, depression, schizophrenia, Alzheimer's, Huntington's, and Parkinson's. Okay, let's first address the location of synthesis, because this is more important, because this is more physiological and everything will make sense once we know all the diseases. Okay, but this is the part where we have to do baseless memorizations. Okay, okay. So, so for the first one is acetylcholine. Okay, acetylcholine. And for acetylcholine, what I like to think is, okay, so you have, okay, so for acetylcholine, what we have is, okay, so this is an island. Okay, so so bear with me how silly this mnemonic is. Okay, but hopefully it will help you. So this is an island. In this island, okay, you have this table. Okay, so group of group of friends. Okay, we have these friends over here in this island. Okay, who are playing poker, Texas Hold'em. They're playing poker, Texas Hold'em, and every one of them have an ace card. Okay, every one of them have an ace card, and the name of this island is Maynard. Okay, sounds like the name of an island in Game of Thrones. Okay, Maynard. Okay, so group of friends playing poker in an island called Maynard. Every one of them have an ace of spades. Okay, and this mnemonic will help you in identifying that acetylcholine is the location of synthesis is in the basal nucleus of Maynard. Clear? Are we clear? Okay. Okay. If you guys have any other, if you guys have any other mnemonic which you want to use, please feel free to use them. It's not important that you use my mnemonics. Okay. The reason why I do this is because it's because it does not matter how many times you memorize or try to recall all this information. If you do not have a story attached to it, it will be extremely difficult to recall it when you want to. Okay, so next time when you want to think about acetylcholine, think about your group of friends playing poker, ace of spades. Every one of them have an ace of spades in a solitary island. Okay, they want to be away from everyone else, and the name of this island is known as Maynard. Okay, all right. Next one. Next one is dopamine. Okay, next one is dopamine. Okay, so does anyone know what dope is? Okay, well, what is dope? It's not an expression. Anyone, does anyone know what dope is? We, that is correct. Dope is, that is correct. Dope is the slang word for marijuana or weed. That's what it is. Okay, so we have a bunch of dope dealers, or we have a bunch of weed dealers, marijuana dealers, and this another island. Okay, and this is a very peaceful island because everyone is having fun. This is more terrorizing. Okay, and the name of this island, guess. Okay, the name of this island is Tegmentum. Okay, Tegmentum. And over here we have this bunch of drug dealers over here who's dealing dope. Okay, these are my dots for the drug dealers, and this is our view of the island from a very far away. Okay, from space. That's what we're doing. We're viewing all of these things. Okay, silly stories. Okay, I understand. I do not want to annoy you guys. Okay, but I'm trying my best. So we have this island over here. This island is called the Tegmentum Island. And over here, this is famous for dope dealers. Okay, because this is where they hide all their weed. Okay, once again, dope is a slang word for weed or marijuana. So that's what it is. Okay, so dopamine, the location, what is the location? The location is tegmentum, ventral tegmentum. And another one is SNC for subthalamic nucleus. Okay, subthalamic nucleus, and that's what it is. Okay, okay, and that's what it is. So ventral tegmentum, and the ventral tegmentum is a more common location for, I mean, is a more commonly tested location for dopamine. Okay, everyone clear? Let's see if everyone clear or not. Are you guys clear? Okay. So what I would do is what I would do is I would try to read that same amount of drawings in the book to see if it can be used later for your reviewing or not. Okay. Next one is GABA. Okay, GABA is gamma aminobutyric acid, or okay, it's an inhibitory neurotransmitter. Okay, and okay, and we have this one guy. Okay, we have this one guy over here. So this guy has a very big problem. Okay, I don't know why I drew his nose. Okay, so this guy over here. So this guy has a very big issue. Okay, this guy has a very big issue, and the issue of this guy is this guy, whatever he finds, he tries to store. Okay, so he tries to store. So let's say he's like a hoarder. Okay, so basically a hoarder is a person who tries to store everything, basically, who has a hard time getting rid of stuffs. So what this guy does is this guy accumulates. Accumulate is the word that we have used for stores or storage. So this guy helps in accumulating stuff, or accumulates means storing. Okay, and he's a hoarder. And guess what the name of this guy is? The name of this guy is Gabe. Okay, Gabe is a hoarder. Gabe is a hoarder. Gabe tries to store everything. So Gabe tries to accumulate stuffs. Okay, so that's his problem. Okay, so clear? Is this clear? Is this clear? Okay, guys, review and recall it right away. I'll the questions from this table right now. Okay. Okay, so if this is clear, then let's move on to our next one. And the fact that Gabe accumulates, it's the one which we have used for the fact that accumulates for accumbens and Gabe for GABA, and Gabe for GABA, and accumbens means nucleus accumbens. Okay, nucleus accumbens. Do not worry, we will show you these nucleus and these locations in a scan format, or how they're present in the CT scan. So do not worry, we will keep this for the last lecture where we will show high yield CT scans. So do not worry, we will show this. Okay, but first of all, let's try to recall and remember the locations before we address the CT scans. Okay, next one. Okay. Okay. Next one is, thankfully we do not have any drawing, but we have a very simple mnemonic. The simple mnemonic for norepinephrine is norepinephrine helps us focus. Okay, so norepinephrine's, what do? They help you focus, or they help us focus. And for focus, we have locus ceruleus, which is present in the pons. So locus ceruleus, and locus ceruleus is the location of norepinephrine. Okay, so please write this down. Norepinephrine helps us focus. Focus is the mnemonic for locus ceruleus. Okay, so norepinephrine helps us focus. Focus for locus. Next one is serotonin. Okay, another one, serotonin makes us happy, or happy for Raffi nucleus. Okay, happy for Raffi nucleus, that's what it is. So once again, what is acetylcholine? A bunch of friends in an island called Maynard playing with ace of spades. Acetylcholine. Okay, next one is drug dealers, meaning weed dealers dealing dope in an island called Tegmentum. Okay, who is Gabe? Gabe is the guy who is a hoarder who helps store everything. Okay, so Gabe is GABA, and storage for accumulates is nucleus accumbens. Okay, norepinephrine helps you focus, so norepinephrine is present in the locus ceruleus. Serotonin makes you happy meaning happy. Okay, and happy for Raffi, so Raffi nucleus. Okay, so did you guys write all of this down? Okay, if you guys are I give you guys full liberty to memorize these knowledge without using the mnemonic. Okay, that's up to you. but if you can use the mnemonic, that's okay. I sometimes kind of judge myself for coming up with these mnemonics, okay, because it's extremely stupid, extremely annoying, but I hope it will help you guys to recall these things, okay? So even if you guys get a laugh out of it, if it still helps you guys remember the information, then I have succeeded on my end, okay? Okay, so who is ready for recap? If I can post these in the groups, you will be happy. Of course, I can post them in the group, but if you share them with your friends, they will laugh at me. So please try to keep all of these between us, okay? Because, okay. Okay. If you share these with your friends in your college or in your hospital, they would think that I'm some stupid tutor who's trying to teach you stupid, okay? But they would not understand how we address the whole thing, okay? Okay, so who is ready for the participations? Okay, it's discrete. Okay, we have. Okay, so Dr. Kameshwari, do you win meme or Mimi? Like you are ready? Oh, me? Okay, good. Okay. Okay, good. So let's start with Dr. Kameshwari because you have not been given the chance to participate. After that, we'll go to Dr. Uday, then we'll go to Dr. Hassan, we'll go to Dr. Irene. Okay. So let's start with Dr. Kameshwari. Let's see where you are.
Yeah, hi.
Okay. Would you be kind enough to tell us what is the location of norepinephrine and what is the mnemonic? Yes. Can you hear my voice?
Yes.
Okay, perfect. So my question was, what is the mnemonic we used for norepinephrine and what is the location of norepinephrine synthesis?
The mnemonic is norepinephrine helps us focus. Focus in
Okay,
the sense locus coeruleus.
perfect. Okay, and let's ask you another question. What is the mnemonic that we used for GABA? And what is the
GABA,
location?
yeah, GABE accumulates. So
Okay,
GABE
good.
in the sense GABA and accumulates is nucleus accumbens.
Okay, thank you so much. Can I ask the next doctor the question? Before I do that, I just need 1 minute, please. Okay. Okay, that was a scam call. Okay, all right. So the next doctor is Dr. Uday. Let's see where you are. Okay. So, okay. So would you be kind enough to tell us what is the location of synthesis of dopamine? Dr. Uday? Can you hear my voice? Dr. Uday, can you hear my voice?
Yes, I'm here. Hello.
Okay, okay, yes, hi. So what is the mnemonic we used for dopamine, please?
Dope, like weed on an island called Tegmenta.
Okay, so what is the location of dopamine synthesis?
Tegmenta.
Okay, I think I heard you say ventral tegmentum. Is that what you said? If that's what you said, then you're absolutely correct. Okay, I guess that's what you said. Okay, we are having a difficulty hearing you, Dr. Uday. Okay, and unfortunately, that's it. And thank you so much for participating. The next question goes to Dr. Hosam. See where you are. Dr. Hosam, would you be kind enough to tell us what is the relation of synthesis of serotonin?
Yes, doctor. Serotonin is produced by serotonin makes us happy, so
Okay,
it's
good.
produced by macros RAFI.
Rafi nucleus, good. Okay, let's go to the next doctor over here. The next doctor is Dr. Tani. Would you be kind enough to tell us what is the location of synthesis of acetylcholine?
I buy AC from Maynard, so the basal nucleus of Maynard.
So this is the basal nucleus of Maynard. Okay, so that's what it is. And thank you so much once again for participating in all of the locations. Okay, and now what we would be doing is we would be focusing on the increases and decreases. But what I personally want to do is I want to come and address this increases and decreases of the neurotransmitters after we are done talking about the diseases. Okay, so do you think that's a good idea? Because if we talk about this right now, it will be baseless because we won't have any idea. Okay. Okay, good. Okay, so let's first okay, so let's first learn about the diseases, and then we will come back to this. Okay, so if we can have anyone who can remind me if I overlook this after the pathology section, please try to remind me if I have overlooked this. Okay, and then I will come and discuss the second, but hopefully I will not. Okay, so just in case I do. Okay, next one. Next one is meninges. Okay, so we have come actually quite far. Okay, next one is meninges. Okay, and what we would be doing is let's talk about the meninges. The meninges are basically the three meninges that surround and protect the brain and spinal cord. I'm pretty sure you guys know what the meninges are. The meninges are your DAP. Okay, DAP are dura mater, arachnoid matter, and pia mater. Okay, so the dura mater is a thick outer layer. Okay, so this is the dura mater. Okay, and in between the dura mater and the arachnoid matter, you have these veins, and these veins are known as bridging veins. Okay, so these veins are known as bridging veins, and between the arachnoid matter and the pia matter. Okay, and then you have the arachnoid matter, which contains web-like connections, and this is derived from the neural crest. This is important. The dura mater is derived from the mesoderm, and the pia matter, it is derived from the neural crest once again. So once again, you do not have to focus on the derivatives of the layers right away, because we will be addressing this in the embryology section of the reproductive system. Okay, so just try to recall that you have the three layers, that is DAP, DAP for dura mater, arachnoid matter, pia matter, and between the dura mater and the arachnoid matter, you have the bridging veins. Okay, next one. Next one is so in between this subarachnoid space, meaning if this is the dura, arachnoid, and pia, then the space between the arachnoid and the pia matter is known as the subarachnoid space, and this space, it contains CSF. Okay, so CSF flows in the subarachnoid space. Okay, and what is the epidural space? The epidural space is the space between the skull. So you have the skull, okay, and then you have these layers which are covering the brain and the spinal cord, right? So the space between the dura and the skull, this space is known as epidural space. So epi meaning above the dural, meaning epidural space, and this is a potential space for this is the potential space for blood collection. Okay, so what would happen is this space, it contains an artery which is middle meningeal artery. Okay, so we have middle meningeal artery, and we also talked about another vessel, that is the bridging veins, which is present in between the dura and the arachnoid matter. Okay, so subdural, and so epidural, it contains meningeal artery, and subdural, it contains bridging veins. So write this down because this is important for hematomas, which we would be focusing later. So for hematomas, for subdural and epidural hematoma, you have two types of vessels which can rupture and give rise to the hematoma. So for epidural, we have middle meningeal artery. For subdural, we have subdural, we have bridging veins. Okay. Do you guys write them down? Do you guys write these down? Did you guys write these down? Okay, all right. Okay, good. So that's all you need to know from the meninges, from this part. Okay, the next one is your blood-brain barrier. Okay, so this is your blood-brain barrier. So what is the blood-brain barrier? Blood-brain barriers are basically, so you have these blood-brain barrier which prevents, so you have substances in the blood okay, for example, bacteria and drugs, which are prevented from entering the brain and spinal cord, right? And this barrier, which forms a tight barrier, this barrier is known as the blood-brain barrier, meaning this barrier prevents the substances in the blood to reach the brain, as simple as that. And what are the structures that is used for forming this blood-brain barrier? The structures that are used are basically these um, three structures. Okay, so we have the first structure, which is non-fenestrated capillary endothelial cells. Okay, so how many types of capillaries do we have? Does anyone know? How many types of capillaries do we have? What are the three types of capillaries? Number one, what are the three types of capillaries? Anyone else? Does anyone know the three types of capillaries? Anyone? Okay, so okay, so the right. So the three basically continuous, fenestrated, and non-fenestrated. As simple as that. Okay, so we have continuous, fenestrated, and non-fenestrated, or continuous, fenestrated, and sinusoidal. So basically meaning the same thing. Okay, so basically they mean the same. So out of them, the fenestrated, the non-fenestrated ones, meaning that they do not have any fenestra, fenestra meaning space. So they do not have space, meaning that they form extremely tight junctions. These are the capillary. Okay, and what they do is they form extremely tight junctions in between one another. So that's number one. Okay, the next one is the basement membrane. Okay, so this basement membrane over here. Okay, that's the second layer. And the third one are astrocytic food processes. The third one are astrocytic food process, and these are the astrocytic food process. These are the astrocytic food process, and the blood-brain barrier is formed by these three structures. So first of all, what is the first structure? The first structure is tight fenestrated endothelial capillaries. Okay. The next structure is your basement membrane, and the third structure is astrocytic food processes. Do you guys understand the structures? You guys understand the structures? Okay. Who did not understand the structure? Anyone else? Okay, good. I guess everyone did. Okay, next one. Next one is, so what happens is the glucose and amino acids, they cross slowly. Okay, so in between these structures, you have the glucose and amino acid, which can cross very slowly. Okay, but the substances, because if they're lipid soluble, then they allow from the membrane to membrane transfer. So that's why the lipid substances can cross very rapidly. Okay, these are not that high yield. Okay, what's high yield is circumventricular organs. Okay, so what's high yield is circumventricular organs. What are circumventricular organs? So basically circumventricular organs are there are spaces in the central nervous system in which there are breaks in the blood barrier, meaning that over there they allow communication with the brain and the blood. And why is that important? Because there are certain substances in the blood which has to stimulate certain parts of the brain so that a certain response can be stimulated. Let's say that let's say your blood. Okay, so let's say this is your brain. Okay, and your brain has a barrier. Okay, so let's say your brain has a barrier over here. Okay, and now your blood, what this is, let's say is your blood, and let's say your blood contains substances. These substances are let's say these substances are toxic. Okay, let's say these substances are toxic. So, and your body has a protective mechanism, which is vomiting. Okay, so vomiting is a sort of protective mechanism. How is this a protective mechanism? First of all, if you vomit out, okay, this will help the body primitive. It's a primitive mechanism in which your body will try to vomit or regurgitate to get rid of the toxic substance out. So how is that vomiting taking place? Okay, so the vomiting is the response, and the stimulus is the toxic substance that is present in the blood. And if this blood cannot go and stimulate the vomiting center in the brain, then your vomiting will not take place, right? So in order for this blood to go to the brain, to a certain part of the brain and stimulate the vomiting center, there has to be a break in the blood-brain barrier. There has to be a break in the blood-brain barrier, and through this break, the blood goes, okay, and then it stimulates the vomiting center. Okay, this is just an example. And these physiological breaks, okay, these are not pathological breaks. Okay, okay, so we have one student who wrote post-trema, meaning area post-trema. Area post-trema is a very high yield area for vomiting. Okay, so that's very good. Okay, so basically these breaks are physiological breaks in the blood-brain barrier, and these breaks are known as circumventricular organ, CVO, or circumventricular organs. Circumventricular organs. So circumventricular organs are basically physiological breaks in the blood-brain barrier through which substances in the blood can go and stimulate certain parts of the brain for a certain response. Okay, so circumventricular organs they have fenestrated capillaries. Okay, so circumventricular organs, the break is through the space in between the capillaries, and these capillaries right now are fenestrated capillaries. Keep in mind that the capillaries for blood-brain barrier were non-fenestrated. Okay, and when they go to the when they go to the brain, there are certain circumventricular organs, for example, area postrema. Okay, and then we have another high yield organ, which is known as organum vasculosum of lamina terminalis. Okay, in short, it's called OVLT. OVLT is used to detect the serum osmolarity. Okay, so serum osmolarity, and then they help increase or decrease the ADH, right? So these are examples of circumventricular organs. So area postrema, for example, is an example. Organum vasculosum of lamina terminalis, or OVLT. This is another example. Okay, or you have neurosecretory products, let's say from the pituitary glands, right? Neurohypophysis, which secretes ADH, that also occurs to the circumventricular organs. Okay, and that's basically it. And another thing which we have to understand is this thing called vasogenic edema. Okay, so if you have an infection or a neoplasm, okay, so if you break down, let's say you have a barrier, okay, if you break down a barrier, this creates a space in between, this creates a space through which fluid can leak in. So this creates a space to which fluid can leak in and fluid can leak out. Okay, so this leakage out of fluid into the interstitial space of the central nervous system due to the fact that there has been a breakage is known as a vasogenic edema. This is a very high yield pathological condition. For example, in certain conditions such as meningitis, you can have vasogenic edema, and vasogenic edema is a very threatful condition because if it's not controlled, then the patients can get pressures on the vessels, and this can result in ischemia of certain structures of the brain. Okay, so vasogenic edema. Why is vasogenic edema occurring? Because there is a disruption of the cells of the blood-brain barrier. Okay, and then you have certain substances such as hyperosmolar agents. They can directly go and disrupt the blood-brain barrier, and that's another high-yield information. Okay, so that's that. Okay, did you guys understand blood-brain barrier and circumventricular organs? You guys understand blood-based and circumventricular organs? Anyone? Circumventricular organs are basically physiological breaks in the blood-brain barrier where substances in the blood can go to certain parts of the brain and exert a response. Okay, that's your circumventricular organs. What are the organs? Is this break in circumventricular selective? It's a physiological break, meaning that the breaks have always been there since beginning. Okay. Is that understood? Okay, perfect. Now the last one that we will talk about is the vomiting center. Okay, the vomiting center. The vomiting center is basically, this is coordinated by the nucleus of tractus solitarius in the medulla. Okay, so the nucleus of tractus solitarius is an important high yield nucleus for the medulla. Okay, and this receives information from the chemoreceptor trigger zone, meaning that the area postrema, which we just talked about, okay, the area postrema, which we just talked about over here, which is a circumventricular organ, this goes and this triggers the nucleus of tractus solitarius. Okay, and this is triggered by either the chemoreceptor trigger zone, or by the GI tract, or by the vestibular system. Okay, so let's break this text down because this is a very high yield text. Okay, so what's happening over here? Okay, that's what's happening over here. Let's take another page. One second, please. Okay. Okay, so what's happening is we are talking about the vomiting center. Okay, so let's say this is your patient. Okay, okay, and now this patient is vomiting. Okay, okay. So why is this vomiting occurring right now? Why is this vomiting occurring? What's the physiology behind this vomiting? So we know that there are certain reasons why a person vomits. Okay, first of all, could be some sort of a toxin. Let's say if you have food poisoning, you have toxins of the food poisoning which goes and stimulates the GI tract. And the GI tract, what this does is when the GI tract gets activated, okay, this goes and this stimulates the vagus, okay, the vagus nerve. Okay, in the same way, let's say if you have in the same way, let's say if you have vertigo, okay, let's say if you have vertigo can also cause vomiting center, can also cause vomiting. Okay, and one of the most important cause of vertigo is BPPV, benign paroxysmal positional vertigo. I'm not sure if you guys have learned this or not. If you have not, it's not important. Right now, we will focus on this later. So let's say in vertigo, okay, vertigo, what you have is vertigo is a problem of the vestibular system, meaning that the endolymphatic channels, if there's an increase in endolymphatic fluid in the channels, this can cause vertigo. And what vertigo does is, so if this stimulates the vestibular system. Okay, vertigo, vestibular system. Okay, and then you have certain infections. Let's say if you have a blood infection, okay, if you have a blood infection in the blood, you have toxic substances, and this can go and directly activate the circumventricular organ, that is area postrema. That is area postrema. Okay, area postrema is a circumventricular organ. And all of these, what they will do is, these are all stimulus. Okay, all of these will go to one nucleus, and that nucleus is nucleus tractus solitarius. And that nucleus, where is this located? This is located in the medulla. Okay, and once this nucleus of tractus solitarius is stimulated either by GI, or either by vertigo, or either by some sort of infection through the area postrema, the person has, I mean, your patient has regurgitation, and the patient starts vomiting. Okay, and the patient starts vomiting. So the next time, if let's say if you are a researcher, okay, let's say if you're a researcher and you have a lab mouse, okay, if you stimulate the nucleus of tractus solitarius in the mouse, in the medulla of the mouse, you will realize that the mouse will start vomiting without any reason. If you can properly stimulate it, this can result in vomiting by your lab mouse. Okay, so is everyone clear? Is everyone understood? Has everyone understood the mechanism of vomiting? What's happening over here? Okay, step by step and down, step by step breakdown of vomiting. That's what's happening in vomiting over here. Okay. Next one. Next one is, why is this mechanism important? This mechanism is important because we can treat vomiting by certain antiemetics. Antiemetics are basically your 5-HT3, meaning 5-hydroxytryptamine, D2 or dopamine blocker, and neurokinin antagonists. Neurokinin antagonist. So basically the chemoreceptor trigger zone. Okay, so the chemoreceptor trigger zone, they have 5 major receptors. The receptor muscarinic, dopamine, histamine, serotonin, and neurokinin. And if you can block these receptors, then you can stop the patient. Can I get 1 second, please? Okay, so once again, let's look at the text. The text has basically you have five major receptors. The receptors are basically your muscarinic, dopamine, histaminic, serotonic, and neurokinin receptors. And if you block these receptors, then you can target the vomiting. I do not want to talk about these right now, right away, but we will be talking about this in the pharmacology section. We talked about this a little in the GI part of pharmacology, and then we will also talk about this in details in the neuropharmacology. But have you guys understood the steps of vomiting? Have you guys understood the steps of vomiting? Okay. Okay, perfect. So leave up to here. Is that okay? Because I do not want to put a lot of stress by putting a lot of information. Okay, I want to. Okay. Okay. All right. It's 1 p.m. Do you want to study more, Dr. User one? Then we can continue. It's 1 p.m. because is it late, or do you want to keep on continuing? Dr. User one, anyone can answers over here. It's okay. Oh, okay, it's late. You wanted to continue more. Okay. Okay, so the reason is I do not want to put a lot of pressure by trying to finish everything in one day. Okay, so that's why I kept up to here. Let's see how many pages we did. We did around, our goal was to do 12 pages. Let's see how 1, 2, 3, 4, 5, 6, 7, 8. We did around 8 pages. Okay, we did around 8 pages. It's hard. Oh, they're around 7 pages. Okay. Okay. So is okay. So the thing is, what we do is what I would do is for today, I would like to end the lecture over here right now, and I would be providing the UWorld notes for today directly in the group. Okay, directly in the group. I would like to end the lecture over here, and I would like to the UWorld notes directly in the for the fact that I didn't have a very important meeting to go and attend by 2. Okay, so I will be in a bit of a hurry. So if you guys can accept my apology for ending the lecture early today. Okay, but okay, so if that's the case, then I would like to end my lecture over here for Nikki. And then I will post the URL notes directly to the group once. Okay. Okay, perfect. Okay, if you once again, my apologies. Okay, I wanted to do us a bit of URL notes, but any problems URL notes collection, because I will upload the notes directly in your group. Okay, and I will start the lecture tomorrow at 9 a.m. And tomorrow we will be focusing a bit. So for this week, we will be focusing a little on revision and recapitulation, and we will be focusing a bit more for we will be focusing a bit more on finishing the chapters. Okay. Thank you, Dr. User One, for understanding. Okay. So okay, yeah, so it's better because it's a long topic, so we don't have a lot of time on doing revision and recapitulation if we want to finish everything within 3 months. Okay, so that's our goal. Our goal is within 3 months, so that's what we're gonna do. So hopefully that's that. If all is well, okay, I would like to take my leave for today, and hopefully tomorrow we will see each other at 9 a.m. And please let me know if you have any questions or concerns. Okay, thank you so much to all the students who have completed their transactions last week. Okay, this means a lot to us because this helps us provide the proper lecture days at the proper time. And to all the students who have not yet finished their transactions, thank you to you too for letting us know that you need extensions. Okay, because once again, we do not do this solely for the purpose of earning money. We do this because we like tutoring. And but if you can just let us know that you are having your extensions, I mean, if you're having issues with your payment or anything, I'm more than happy to consider. Okay. And that's that. You had questions regarding your 1 month. Okay, so we using your questions in your email. Okay, if there's anything wrong with our end, we will address it. If there is something wrong with yours, we will address it too. Okay, but that's that. Okay, so all your quick queries regard. We had another question, which was on to my email about cardio videos. Of course, we'll try to respond to the emails about the cardio videos. The reason why it's taking us time is because only two of us who work in organizing our lectures. Okay, and we were trying our best to juggle everything. Okay, so taking lectures is not the main thing. We also have to address everyone's emails, and at times takes us a bit of a time to answer everyone. Okay, but we're trying our best to let everyone know that we're there. Okay, that we're there for them. So that's that. Okay, so with that being said, hope you guys have a great day today. Okay, early finish to the lectures. Okay, this gives you one more extra time to watch an episode on Netflix if you that's what you're doing. Okay, if you guys are, then watch the series called Evil. Amazing series. It's based on a psychiatrist and another. It's just an amazing series as a, like all in all. Okay, so if you guys are looking forward to watch a series, okay, Evil is the one that you should go out for. And it's an amazing series. We started watching it recently. Okay, and that's that. Okay, hope you guys have a great day. We will set your recording for Saturday. What is the name, please? The name of the series that is amazing in Netflix that I think you guys should all watch is called Evil. Okay, it's Evil. Evil is an amazing series. We started watching it very recently. It's an amazing one for medical students. Okay, if you're a psychiatrist enthusiast. Okay, that's the one. If you guys want to watch anything else and learn more about medicine, you guys are more than welcome to watch House MD. Okay, it's a classic. If not, there's another one which you guys can watch. It's called The Good Doctor. So it's on Hulu. I'm not sure if you guys have heard about The Good Doctor or not. Okay, that's an amazing one. So that's that. Okay. Okay, without further, once again, thank you so much. And hope you guys have a great day. I'll see you guys tomorrow. Please let me know if you guys have any questions. Thank you.